Good morning, dear colleagues. All welcome to today's workshop. Today we are going to continue from where we stopped on Saturday. Some of you may have joined us on Wednesday, where we looked at case studies. So case studies from the systems that we reviewed last Saturday. I think we had neurological, there was cardiovascular, pulmonary, and GIT. So these were the four systems that we studied on Saturday, and it was from those four systems that we picked case studies from the book Differential Diagnosis for Physical Therapists. And today we are going to continue with the screening of other systems of the body, hepatic and biliary system, urogenital system, hematological system. We'll look at pediatrics today also. And then if we are able to complete all this before the end of the day, then we'll begin looking at, because we realized that on Wednesday, we were not able to cover all the case studies that we had because of time, and it was very, very interactive. I appreciated all the comments by the resource persons. And since that discussion is bringing out a lot that's going to help with clinical practice, I think we are going to emphasize more on that, the practical aspect, which is the discussions on the case studies. Therefore, I will take less time with the theory part, go through just to ensure that we understand the concepts. And then from today, we'll start looking at those case studies. Then on Wednesday, we'll continue with the case studies. I think no matter how much time we have between today and Saturday, on Wednesday, we'll not be able to cover all the case studies that are available. And I also want all of us to be able to see a patient and use the information gathered from today's workshop between Monday and Wednesday, so that on Wednesday, we'll prioritize our own case studies. Because most of the case studies that we have in Goodman and Snyder textbook, they are from the US. And there are peculiarities, even though the concept and usually is similar, but the context may be different because of environmental differences that we have. So I want to encourage all of us, when we finish today, use what we have discussed from the slides to assess your patients, and then write a short case report, only half a page, stating relevant patient characteristics, and then discuss what red flags were observed, if it's red flags, discuss them. If it is yellow flags, discuss them, and then let us know what your decision is. Are you referring or are you keeping the patient? If you are keeping the patient, what sorts, because if there is a yellow flag and you are keeping the patient, then there are further investigations or further observations that you need to do before you confirm if there is a red flag that requires referral to a physician, or if there is no red flag, that you continue to keep the patient and treat them. So this is something very important, because if we don't put it into practice, we'll lose it. So I will encourage us, each and every one of us, after today's workshop, that we go back to our patients, pick this information, ask the questions, do your observations, do your tests, and then record what you have done, and then state what the red flags or yellow flags are, and then state what your decision will be. Thank you. So as I've said, today we are going to continue with, we'll start from hepatic and biliary disease. If you know the organs and their function, hepatic system is the liver, while the biliary system are those ducts that connect the hepatic system and the gallbladder, and then the gallbladder to the small intestine. So the liver produces the bile, and it's taken through the bile duct to the gallbladder, and it's stored there. And when needed in this intestine, after food has been ingested, there is fat in the food, the bile is released from the gallbladder through the biliary system or the bile duct. It goes into the small intestine, and it helps in the digestion of fat. Now, this is as simplistic as I can put it, simple as I can put it, but it's much more complicated than what I've just presented. But it is important to understand that this is a system that releases substances that help in the digestion of food. Of course, there's also the pancreas, which also releases substances that help with regulation of sugar level in the body, but also with digestion. So it's important to understand that there is a link between the hepatic and biliary system and the GI system. And that is why if there is disease of the hepatic or biliary system, that you are expected to have gastrointestinal symptoms. So when you see gastrointestinal symptoms, it might be from the GIT, and it might be from the hepatic or biliary system. Last week, we discussed the GI symptoms. So they are there, you can refer to them. But in addition to the GI system, you will have edema or ascites. So this is accumulation of fluid in the abdomen. And when you are assessing the patient, you can either palpate, and when you palpate, if there is fluid, you will have that feel of fluid accumulating in that part of the abdomen that you are palpating. Or you can do auscultation. You want to tap on the stomach. So if it is air that is around the place, the sound that it gives is different from a sound that you have when you have, for example, a balloon that has water in it. So that tap will determine whether there is fluid accumulated in the abdomen or there is no fluid accumulated in the abdomen, because there are a number of reasons why you can have bulging of the abdomen. And if it is fluid accumulation, you should be able to feel that from the palpation or from the auscultation. So when you palpate or you auscultate, you'll be able to know if there is ascites or accumulation of fluid in the abdomen. It's important for a patient when doing system review under hepatic and biliary system to ask them about the color of their urine. So color of the urine could be a problem in the hepatic or biliary system, or it could be from the urogenital system. We are going to see this issue of color of urine also under urogenital system. But if the color of the urine is dark and you have that ascites and GI symptoms, and also the feces, so the patient is asked the color of their feces. Is it light colored or clear colored? So if the urine is dark, the feces color is light, and the patient reports pain in the upper abdomen. So they have pain, but it's in the upper abdomen. We know lower abdomen, you will have things like what we discussed, appendix, when we looked at the GIT last week. So, but upper abdominal pain, of course, there could be more than one reason why you can have pain in the upper abdomen. But when pain in the upper abdomen comes together with other GI system symptoms, ascites, dark urine, and light-colored feces, put together, they form a red flag for hepatic and biliary disease. And this is a red flag. It requires referral immediately. I've told you, I said this during the last 2 lectures that we've had, that key to understanding systems review is understanding those symptoms and signs and risk factors. This is number one, most important thing. Number two, how do I assess those things and what results do I see? So this is still going back to our lecture on evidence-based practice, where we discussed the 6 components of patient management. Said examination, that is where you use analytical knowledge. So now we are combining evidence-based practice and clinical reasoning lectures. These are 2 separate lectures, but they are linked to each other. In evidence-based practice, we discussed the 6 components of patient management. And in clinical reasoning lecture, we discussed how you can gather the information about how to achieve each of those 6 components of patient management. And we said for examination, you need knowledge about risk factors, symptoms, and signs of diseases. And how do you get that information? Initially, at the beginning, when you don't know anything, you use analytical cognitive processes. So what we are doing now is an analytical cognitive process. Maybe some of you didn't know. If I'd asked before we started this lecture and said, what are the risk factors, symptoms, and signs of hepatic and biliary systems? Either we don't know them or we can't remember them. Some of us may not be able to say these things that I've said. But now that we are going through these slides, you are reading it, you are listening to me say them out. When we finish, you'll go back to the textbook and you'll read more. This is an analytical cognitive process. So in examination, you are going to assess them. And that is the explanation that I was giving. We did GI symptoms last week. Today we are looking at edema and ascites, and I'm explaining how do I now examine, how do I assess? Say you observe, you are going to see the bulging in the tummy. So you now palpate. So while you are palpating, you are feeling the place you are palpating to see if there are signs of accumulation of fluid there. And also you are auscultating. On the tummy, you are tapping to see the sound. Is it a sound that there is fluid there, or is it air that's there? So this examination, the process is to palpate or to auscultate. The result is the sound you hear or what you feel as you palpate. The next in the components of patient management is evaluation. And that is where interpretation of the results come into play. So usually you can interpret one result of one examination. Sometimes the result is a clear case, but for you to make a decision as to what the problem is, you will need more than one examination. Then you put together the results and you will interpret, as it is in this example. So you have the GI symptoms, it's an examination. Edema or ascites is an examination. Information about the color of the urine, the result is that it's dark. information about the color of the feces. The result is that it is light colored or clay colored. You ask about the pain of the patient. Where is your pain located? The patient says the pain is located in the upper abdomen, and they touch the upper abdomen. All this are single examinations or assessments or observations. But when you put them together, you are now interpreting. Whenever you have GI symptoms, ascites, dark urine, light-colored feces, and pain in the upper abdomen, the interpretation is that the patient is suspected very strongly, because it's a red flag, that the patient has hepatic or biliary system problem. Therefore, this is the interpretation. This is the evaluation, meaning evaluation comes from looking at the results of individual examinations, and then you interpret all that to narrow down from thinking of all conditions to coming down to a particular condition, especially at this point, a system, not a condition. So this is analytical cognitive process. If on Monday you go to the clinic and you are applying this information to a patient, so a patient comes and he has GI symptoms, and you want to differentiate between those symptoms, whether they are coming from disease in the GI system, or is it a disease in the hepatic and biliary system? And you want to now go further to make further assessments to confirm which of the two systems the patient may have a problem with. You now ask the patient, well, I can see your tummy is bulged. Can you lie down? You now palpate, you tap, and you see that there is ascites. You ask the patient about their urine color. You ask the patient about their feces color. You ask the patient about their pain in the abdomen. While you are doing that, what will be coming to your thoughts, your mind, will be what we did today, which is analytical cognitive process. But by the time another patient comes on Tuesday, another patient comes on Wednesday, you do this process. Possibly you'll be thinking of this lecture or the textbooks that you have read. Over time, after a few cases that you have seen that are similar, when another patient comes, you are not going to think of this lecture. You'll think of the last few patients that you have seen, how you assess them, and how you got the results, and how you use the results to do an interpretation to suspect the hepatic or biliary disease. That process of thinking of the last few patients that you saw is called a non-analytical cognitive process. And in education, teaching and learning, looking at learning styles, it has been shown that when you listen or read, you retain about 10 or 15% of what you have learned. What this means is that if on Monday you go to assess a patient, maybe you only remember ascites after seeing the GI symptoms. You may have to go back to these slides to say that what were those other symptoms that they mentioned, that the facilitator mentioned during the lecture. Then you remember the issue of color of urine, you remember the issue of feces and upper abdomen. When you go back, believe me, you will still forget one, that you have to come back to the books. So you retain 10 to 15% of what you listened to. But when you apply on the patient, the ones that you apply on the patient, you are more likely to remember 70% of what you have applied. So that when next you are seeing another patient, it comes to your memory faster because you have applied it. You didn't just listen. That is why when I teach, I always tell participants that, look, get involved in this discussion. When you say it back after someone has said it to you, you will remember 70 to 90%. But if you are passive, you just sit down and you listen, you will remember only 10 to 15%. And this is a fact because it's a research that has shown that, research in education. So what we are doing here is analytical cognitive process, but what you apply in patients is non-analytical cognitive process. So if your thought goes back to the slides, it's analytical. If your thought goes back to what you did during the application in clinical practice, it is a non-analytical process. So I'm taking this time to bring in the lectures that we had in evidence-based practice and clinical reasoning, because that is the reason why we did all those before we did this. And of course, in the 6 components of patient management, after evaluation, which this slide is exactly on evaluation, we then have diagnosis. So because you are a physiotherapist and you are trying to establish what the problem is, and you suspect strongly through a red flag that this is an organic pathology, then you are not going to go ahead and make the diagnosis, but you are involved in the diagnosis process because you are the one that made the suspicion that the diagnosis will be an organic pathology diagnosis, which is a medical diagnosis, not a physical diagnosis. You refer, and the physician takes it up from there, and he completes the diagnosis process before planning the treatment and getting the prognosis and then planning the treatment. So which form the 5 components of patient management. But clinical reasoning is key because this is what brings about the evaluation that even makes you to decide that there may be a medical condition or a medical diagnosis that you refer. So next, we have confusion. So when a patient is confused, this confusion might be as a result of a neurological problem. So it might be a neurological disease. So possibly you have a patient that has a neurological problem. They have weakness, they have sensory affectation. But you don't just consider that confusion can only come from primarily a neurological problem. You also want to ask more questions that may indicate that the confusion is coming from a problem in the hepatic or biliary system. Therefore, you are checking for muscle tremors. Muscle tremors are also neurological symptoms. So if someone has Parkinson's disease, they are going to have muscle tremors. If someone has a cognitive problem, they are going to have confusion. So if there is a problem in the prefrontal cortex, the patient is going to be confused. If you have a problem in the basal ganglia, the patient is going to have a muscle tremor. Asterixis or myoclonus, irregular lapses of posture. So usually this is an abnormal contractions of the muscles. So because of the abnormal contraction of the muscles, when you assume or the patient assumes a particular posture, there will be irregular lapses of the posture because it is contraction of the muscles that will affect the positioning in that posture. So this might not be primarily a neurological condition. When you have abnormal ammonia metabolism, so when protein is broken down, ammonia will be produced. The ammonia is expected to be taken out of the system, but it accumulates. The accumulation of the ammonia in the blood within the system could go to the brain, and then it will bring all these neurological symptoms. So this put together, always suspect abnormal ammonia metabolism. So because it's a red flag, you don't have to ask for the ammonia test. You refer, and you state in your referral that while assessing this patient, confusion, muscle tremors, asterixis were observed, which may indicate the presence of an organic pathology You don't even have to say hepatic and biliary disease. It might not be within, it might not be necessary, so that you don't begin to send signals to the person that you are sending the referral to, that you are letting them know what the possible diagnosis might be. So this may indicate an organic pathology, and I'm referring to you for your expert opinion or action. So that way you now refer. So it's up to them to now think. So if in your organization, referral is made to a physician and the physician refers to a specialist, you refer to the physician. But if in your organization, you refer directly to a specialist, this is a case that can go to either a neurological specialist or someone that deals with hepatic and biliary disease, the specialist in that field. Then another red flag is when you have itching, pruritus. So the patient reports always feeling that they want the itching and that they want to scratch. Or while they are sitting there, you observe that every now and then they scratch their skin. Or when there is jaundice, when red blood cells are broken down, you will have bilirubin, and this should be taken out of the system. If it accumulates in the system, because the hepatic and biliary system are not able to do the function of taking it out of the system, just like the excess ammonia, then you are going to have yellow coloration of the eyes and the skin. So when you see that yellow coloration, the patient itches, keeps scratching the body, and the patient is pale. So most of this skin observations and symptoms, they are more obviously seen in someone that is very fair in complexion, mostly. So you see that it's red, but now it's looking whitish. It's pale. So usually, for example, when you have anemia, when you have orange or green skin, when there's bruising, you ask the patient, did you have any accident? Did you fall? Did you scratch your skin on something? They say none of those things, but there is still bruising in the skin. When you have spider angiomas, which is a collection of blood vessels on the skin surface that is abnormal, because sometimes you can see collection of blood vessels, but when you see that it's abnormal, the collection of the blood vessels, when you have palms of the patient is looking more reddish than normal, called erythema. So these symptoms put together form a red flag for hepatic and biliary disease. But the issue is understanding what to see. If I just read this and I say jaundice, say spider angiomas, palmar erythema, when you see the patient, what are you expecting to see in the patient? These are just symptoms. But how do I assess to know that those things are there? Just like we did with ascites. We just say ascites. What does it mean? Okay, I can even know what it means, but how do I know it's there? So I palpate, I auscultate. And then there are other tests that could be done. Or ultrasound. I can do an ultrasound. An ultrasound will show you that there is accumulation of fluid there. Other things can also show. For example, if for any reason a CT scan is done, because I doubt if anyone will want to do a CT scan to see if there is ascites. But for some reasons, maybe there's pain in the back and they suspect something in the spine and they do a CT scan and they stumble on the result, that there is accumulation of fluid in the stomach. So there must be a process where you are going to identify that that symptom or sign or risk factor is there in the patient. Very important, because you can't do interpretation without that. So jaundice, you see the yellowish coloration in the eyes. So you just open the eyes of the patient, you look at them, and you see it's yellowish. You look at the skin of the patient, it's supposed to be red, and now it's whitish. See, the patient has pallor, or the patient is pale. You look at the skin color, you see it's orange or green. You expose, so you have to expose the skin of the patient. You see bruising. You look at the collection of the vessels, and you see that it's abnormal. So usually these kind of things, say this is normal, this is abnormal, just Google it. Abnormal collection of blood vessels. Then click on image, and you'll see several images. So when you see that, now if you want to see what happens in someone that is dark in complexion, then you see abnormal collection of blood vessels, or spider angiomas and dark skin. Maybe we'll do that at some point in time before we finish this, so that we'll be able to see different colorations that will help us now to remember when we come to see a patient, what do we expect to see to know that one of these symptoms is present. And when we have a collection of these symptoms, we'll say that our interpretation is that there might be a hepatic or biliary disease. And this is a red flag. We are referring the patient to a specialist or a physician. Then yellow flags. So remember, yellow flags, you don't refer. Yellow flags, you see them and you walk with caution and you do more observations. Because with yellow flags, what you're seeing is that it might not be that system that has a problem. Remember earlier I was talking about confusion. You can't just see a patient that is confused and just refer to the hepatic and biliary specialist. No. What you do, you continue now to ask whether, apart from the confusion, there are other symptoms that put together they form a red flag. So in yellow flags, you are seeing a particular symptom, a particular risk factor, or a group of risk factors. And you will say, okay, let me do more observations so that I will get more symptoms that put together with this one that I've seen forms a red flag. And then it is at that point that you're going to make a referral. Patients that are on anti-inflammatory drugs, or they are taking minor analgesic agents. So any patient that comes to you, that is why it's very, very important to ask the patient, what drugs are you taking? Remember the template of APTA that we discussed when we did clinical reasoning. We had the clinical reasoning class. There was a section asking patients about categories of drugs. Are you taking this category? Are you taking this category? Are you taking these drugs? And then at the end of the day, you are now asking, is there any other drug that you are taking? When patients usually come to you, sometimes they come with the drugs and say, these are the drugs that I'm taking. Especially those that don't know the difference between a physiotherapist and a doctor, or especially during home visits. Maybe it's a relative, see them. I've experienced that. The first thing they will do is just to bring all the drugs and keep them and say, these are the drugs that I'm taking. So when anti-inflammatory drugs are part of those drugs, or analgesic agents are part of them, it's important to ask those other questions under systems review, red flags of hepatic and biliary disease, because it's possible there could be drug-induced hepatitis. Post-operation, whenever a patient has had operation, they may have non-viral hepatitis. Therefore, it's very important to do system review for the hepatic and biliary system. Then pain at thoracic spine. Now, these are the areas where hepatic and biliary system can refer pain to. We are going to see pictures. So this is something that looks like a musculoskeletal problem. And the patient comes to you, they report pain in the thoracic spine, and you think it is degenerative changes in the thoracic spine, or you think there was a trauma that brought pain in the thoracic spine, or the patient has pain in between their scapulae or on their right shoulder or right upper trapezius. So these are on the right side, or interscapular area, right subscapular area, just below the scapula, but on the right. So whenever you have pain, the patient has pain in any of these areas or a combination of them, you need to do more assessments to be able to see if there is a red flag for hepatic and biliary system. Whenever there is tenderness, sorry, you see that I'm sluggish today compared to last time. Yesterday, from morning till late in the evening, I was busy with activities. I didn't sleep well, and I woke up early, so just bear with me. Tenderness anteriorly, so over the ribs, especially the 10th, 11th, and 12th, because that's where the gallbladder is located. So when a patient reports pain, when you palpate the ribs around the 10th, 11th, and 12th, so you palpate those ribs around that location of 10th, 11th, and 12th, and the patient either reports pain or they wince, then it's a yellow flag. Because it could be that it's coincidence, that it's a musculoskeletal problem around the 10th, 11th, and 12th ribs. It's possible. But during your examination, you ask questions about accident. You ask all the questions that could bring tenderness in the musculoskeletal system around that area. They are all negative. You now begin to ask questions about symptoms of hepatic and biliary disease, and you see that they are positive, then you can implicate the gallbladder and refer the patient to a physician. So these are musculoskeletal presentations, but at the end, they give rise to the suspicion of an organic pathology, and a referral may be required. So these are some of the areas where hepatic and biliary disease can refer pain to. Remember last week we talked about the shoulder. The shoulder receives referral the most from organs of the body. Remember also I mentioned the 3 different ways that pain could be referred from one part of the body to another. I keep repeating these things because I understand that it's not everyone that has attended all the series that we have had so far. And the reason why we did all the earlier ones is so that we can connect with the current information that will be given. So the 3 different mechanisms for pain referral. Number 1, we talked about the embryo. Said at the level of the embryo, there are parts of the body that they are at the same level. But as the fetus grow and become a child, is born, those structures now move away from each other. So one will be above, one will be below, one will be at the side, one will be on the other side, wherever they are. If they were at the same level when it was an embryo, one structure can refer pain to another structure. Then the second mechanism is shared pathway. You know, in the spine, at every level that you have a root, nerve root, it goes out. You are going to have one going to the musculoskeletal system, so maybe supplying the muscles and the bones and other structures of the musculoskeletal system. But at the same level, you are going to have another one going to a viscera. So for example, at the cervical spine, you have the nerve going to the shoulder muscles, and you have another nerve going to the diaphragm, for example. And therefore, if you have a problem in the diaphragm, the patient is going to feel the pain in the shoulder, but it is not a local shoulder problem. It is a referred pain. And that is when you palpate, and the patient does not feel the tenderness. Does the pain change? No, the pain does not change. Can you raise your hand? Raise your hand. You put it down. Is there any change in the pain? No, the pain is the same. Nothing changes the pain. Begin to think of a viscera. And therefore, if you know what viscera shares the common pathway, or what viscera was at the same level with muscles of the shoulder or any other part of the body, then you'll be able to say, okay, let me now assess that viscera. So that's part of systems review, to see if it is the one referring pain to that part of the musculoskeletal system or the other way around. The third one is pressure. So we are going to see that under, or maybe we have seen that under the urogenital system. I think is the next one that we are going to look at. So when the kidney is inflamed, it touches the diaphragm. So the kidney itself does not have a direct relationship with the shoulder. The kidney does not refer pain to the shoulder in a direct approach. But because the diaphragm has a link with the shoulder, either through embryological or shared pathway, especially shared pathway, if the kidney is inflamed and it irritates the diaphragm, then the diaphragm will now refer pain to the shoulder. And therefore, it's possible to have pain in the shoulder, and you will need to assess the kidney to see if there are symptoms in the kidney that will show inflammation of the kidney that will explain why the shoulder is having pain. Because what I'm saying this is that we know the structures that refer pain to the shoulder: heart, the lungs, the hepatic and biliary. So these are the ones, and others that we have seen earlier or will see later. But the kidney is not. And therefore, if we have a pain in the shoulder, we might cut short the system review and say that, well, let's check only those that directly refer pain to the shoulder. But then you will miss out an indirect organ that pressures another one, and through that, you have a pain in the shoulder. So you have the shoulder, looking at it in front and around the breast area. But from the back, the liver will send pain referral to the shoulder and to the middle of the back, just in between, just around the subscapular area, but in the center, moving towards the right side. And just then the gallbladder, so this is the liver, shoulder, and that area in the back that I've just explained. But for the gallbladder, we have the trapezius. So you can see this area of the trapezius, and just below the scapula, subscapular. And then in between the two scapulae, but towards the right side. So almost everything is towards the right side of the body. So whenever a patient reports to you with pain in these areas, always suspect the hepatic and biliary system, especially the liver and the gallbladder. This is the organ. The liver produces the bile and other substances. The bile goes through the bile duct to be saved in the gallbladder. the gallbladder will release the bile through the bile duct, and it will come into the small intestine, and the digestion of the fat will take place there. Remember, we talked about the pancreas. This is the pancreas, and the pancreas will release the substances that are required to regulate sugar level and for digestion. So this is just how it looks like. And because it is situated more towards the right, you see the symptoms seen more towards the right. So this is the picture. Now let's look at urogenital disease. But before we do that, let me ask if there are any comments, if anyone wants to share any experiences in this area. We can have a few minutes to do that before we take the urogenital disease. So you can raise your virtual hand and then you can speak. I will encourage discussions sincerely because I can see they help a lot. Yes, Mr. Felix.
Well done, sir. I really appreciate your sacrifice, despite the fact that you are so strong today. God bless you. More grace, more strength.
Thank you.
I just took notice of the place where you talk about the skin coloration, about this green and orange color.
Yes.
For the black, can that be easily noticeable? That can be easily noticeable with the white.
Okay.
But for the black, how do you get that one done? Yes, sir.
Okay. I remember I told you, I said, okay, what I'm going to do, let's go and get the pictures, because usually seeing it, remember I told you, I said, when you listen, 10 to 15%. When you look at it, you return more. You understand? Okay. You return more. Exactly. And then when you apply it, you see it on the patient itself. So it can be noticeable, but it is not noticeable as quickly or as easily as it should be on someone that's
on the white.
Exactly. So what we'll do, can we just Google it so that we'll see it with our eyes? So I'm going to share. Yes, I will share. So can we just pick one of them and see? Let me go back to, so which one are you interested in particular? Is there anyone you're interested in particular, or do you want me to pick any?
You can pick any, sir.
Okay, so let's start with jaundice. Okay, good. I've gotten something, so let me share. Okay, can you see this? Now, this is the color. For the eyes, it's really a big problem. Can you see how yellowish it is? So see how they even just oppose a white and dark skinned person. So can you see there are those that are dark and you are still able to see the yellow. This is a little bit fair skinned, but in this one, can you see some sign of yellowish coloration? Very dark. But even in a dark person, what you do is, for example, picking very black color. Just try it. Pick a black color and put some yellow in it and see what color it will give you. It will not be pure black. The black will be shiny. And that, so this child, I don't think it's a white child, but if it is, you can see the yellow coloration. Trying to see, okay. So usually it will be seen more in the eyes than in the skin. So that's one of the problems that we have. Do you know why we are seeing more of Asians? Because we don't do researches in blacks. We don't do researches here. If we do researches, we upload on the internet, we are going to see something that's related to what it should look like in Africans. But you can see it even in black. But it will not be as easy as you see it in someone that is white. Okay, I've seen a question on the platform, but we'll come to that. So these are most that even in black people, you see some place that's light. So in those areas, you'll see a yellow coloration. And you see here at the tip of the nose, just below the eyes. Even no matter how dark people are, you'll see some areas that are light. In those areas, you'll be able to see a change of color. So let's see another symptom. See palmar erythema. Maybe I said dark skin, let me say black. Okay. So can you see, this is black, definitely this black. But you can see even within the red, the black skin, you can see red. You can see the red here. It's obvious. It's palmar erythema, but it's in a black person. This is in a black person. Might not be as obvious as a white person. Look at this one. This is a white person. Look at this one. It's very red, very dark. This skin is not as darker as this, but I can still see the red. This is also not a white person, but might be light-skinned. See, this is the white. So this is palmar erythema. And you can see it whether it's in black or in white. Only that it's easier to see in white than in black. So let's see palo, say black skin. So see how they just support a light skin. So this is lighter than normal because you're supposed to see some level of red. But see how whitish the hand is. So look at this. It's very whitish. You don't even see any signs of the normal red that you see in the palmar surface. So compared to this, that you see some red. This is whitish. It's whitish. And usually the patient might even report, I see my hand is whiter than it was before. So I think what is important, I remember when we were in, was it primary or secondary school? No, primary school. They will ask us to get colors, blue, red, yellow, and what have you. They will say, okay, add red to green, then you write what color it gives you. Add blue and red, then you say what color it gives you. So if you take black and you add yellow to it, you'll be able to see what color it gives. And then you'll be able to now see if that coloration in the skin of the black is that color that you got from those colors. That's going to help. So this is it. Yes, Mr. Felix, has this helped?
Yes, sir.
Okay.
Thank you so much.
Yes. Yes, Mark, you can unmute and speak. After you, I will read out the comment on the platform, and then we'll discuss it.
Okay, thank you, Prof. Good morning, sir.
Good morning. Yes, you can go ahead, ma.
To see the jaundice in a dark person presented when we were interns. She was really very black, a very black woman, but you could see the jaundice beneath the skin. Of course, the more the jaundice, the more easily it is to see. In fact, you don't even, it's not something you keep searching for. Unless it's very mild jaundice. Even children that have mild jaundice, you could still see it. And when you blanch the skin, when you try to blanch the skin, you see it. So, and even a patient that was cyanotic, we could see the blue coloration. It was a very dark child. So I think it could easily be seen. Thank you very much.
Thank you very much. And I think someone also stated in the chat forum that you can get it with the blanching. So thank you so much, Ma. That also corroborates what someone has posted. Thank you. And see, that's why I was telling you. It's one thing to have the analytical process. It's another one to have the non-analytical process. Can you see someone that has seen it with their eyes? They have practiced it. They are not going back to books. See what I'm doing, going back to Google to show you pictures. But see how someone with experience of seeing it in patients now seeing what they have seen in patients. So I want to encourage you. Go back, even if your patient does not have it, go and ask someone that sees patients with such. I said that, please, I just want to observe in patients that come to you. I want to see jaundice. I want to see when they are pale. I want to see when they have spinal angiomas and angiomas and what have you. Someone just asked about that. I'm going to get that and share. So it's important. That experience that you have seeing it in actual patients, not just reading it or seeing it in pictures. So I'm going to share the slide on. Yes, so this is it. So can you see this is in someone that is light-skinned? These are angiomas. That's not normal. So let me see if I can see anything in someone that is dark. Okay, it's there only that it's not, the picture is not zoomed to capture that. So they're there. They're there. All these are abnormal. You may have even seen this, but the problem is that you didn't even know it is what is called an angioma. You see them, all these, yeah, that. And as I've said, go to someone that sees patients that come with such symptoms. We don't do researches to be able to have them online. And take that challenge, do a research, a case study in that patient, in a Black person, capture, take the picture and publish it. Then we'll now begin to see such. I said black skin, but I'm still seeing white skin because they are the ones that do researches in the area. Yes, Dr. Ajiboye, go ahead, please. When you finish, I will read the other comments on the chat forum.
Thank you so much, Prof, for the opportunity to. Actually, my own is not a question, but I just want to add one thing to examining patients with liver disease or liver pathology. I think one of the most important things to do when we are doing our examination is to check even for the liver span, because the normal size of the liver supposed not to peep from the last rib. But when there is inflammation or when there is pathology there, you realize that it goes beyond the normal. The normal is 140 centimeter. But by the time it's going beyond the normal, it peeps out from the cage. And you can palpate, you can feel it. And there's a way that can be measured in centimeter to know the extent of the inflammation or the extent of the pathology. So knowing that, we give one the impression of the fact that it's not just a referred pain, or it's not because this one is referring to this, but actually there is an abnormality in the liver. So I just want to make that contribution. Okay. Thank you.
Thank you very much, Ma. I agree very strongly, but let me also make a little clarification. Now, if from our assessment, or sorry, let's say an investigation was done, a radiological investigation for something else, and it comes to us, and we have a yellow flag for hepatic system. So we look at that investigation, if it has a result for the liver, what you have just said, to see if we can see something that will help us to add to that yellow flag, to now say there is a red flag, and then we refer. That's fine. Then number two, it didn't even come, but we have the yellow flag. And we may want to just confirm if there is a reason to suspect that there's a red flag for hepatic system to refer. That also, I would say, to some extent, is established a red flag. In as much as that earlier slide that we looked at that said red flag, and it listed the symptoms, and these symptoms come through observations, and we see all those observations are there, and we have a red flag, I will advise us not to ask for a radiological investigation or laboratory test. The red flag is enough to warrant referral. Let the person that is going to make the diagnosis of the organic pathology be the one to ask for further investigations for the purpose of diagnosis. Because we are not going to make a medical diagnosis. When we see a red flag, we don't have any, it's not necessary for us to continue with further investigations that help with diagnosis, because it's a medical diagnosis. But as I've said, I agree very strongly that if we have a yellow flag, and we are not sure whether this is a case for referral, and we want to now confirm if it is a case for referral, that I would say is okay. It's very all right, especially if you already have the investigation for something else that you are only checking. But also to some extent, I would say it's also okay if we are requesting for it with a yellow flag to confirm if there is a red flag. But on the third category, if there is a red flag already from the observations, refer so that the physician will be the one to ask for the further investigations for the purpose of making a medical diagnosis. I hope this is clear, but if you have any divergent views with a superior argument, please just feel free to speak out. Yes, show us spider angioma. I think I've done that. Yes, blanching is one of the signs of jaundice too. The area of the skin turns plain when pressed with the finger. So that's wonderful. This is someone trying to give further information. I've seen spider angioma quite obvious, so that in a patient that had liver cirrhosis was a Caucasian, possibly patient though. So it's good for us to reach out to see if what it looks like in someone that is Black. I think I saw something different. How do you differentiate? Gallbladder pain at back and ulcer pain at back. Patient may have pain at the back due to ulcer. So see, your system review will determine whether it's gallbladder or it is the GIT. So okay, so also it is it urological or ulcer? Okay, that's GIT. That's GIT. Remember, if you go back to the red flags that we have for hepatic and for GIT, they are different. Because with GIT, there are some symptoms that have to do with the pain changing when you eat. I think Sorry, I think I just lost the network. That's back now. Yes, so that's just a little bit. It's just about further questions, because there are some symptoms that you'll only see them in problem of one system and not the other. There are some that will cut across. If you see that one that cut across, then what you do is to ask for further questions to see some symptoms that are only seen in one. And if you remember, we talked about diagnostic criteria. So this is what the principle of diagnostic criteria is, where you have a few that will cut across conditions, but you have others that will only identify one condition and you will not see them in another condition as a combination. So you need to understand those things for you to be able to make decisions. Yes, so I can't see any more hands, so I'm going to go back to the slides. But thank you so much for all that you have shared. Okay, so the urogenital disease, any amount of blood in the urine, any amount of blood in the urine. So whenever there is blood in the urine, you don't need any other symptom to refer the patient. Any amount of blood in the urine, refer the patient, is a red flag. It's an emergency. Cervical spine pain and urinary incontinence. So the patient reports not being able to hold urine, and there is pain in the cervical spine. These two, they form a red flag. Refer the patient. And you know what questions to ask about urinary incontinence. I believe we are going to have a document about questions that you ask. I remember on Wednesday, we looked at questions you ask. I think, is it for pulmonary and for cardiac diseases, so that you'll be able to know if those symptoms are there. So when you say the patient's, you want to know if the patient has difficulty breathing, dyspnea. So what questions do you ask to confirm that it is truly dyspnea? So the same thing with urinary incontinence. Someone may laugh uncontrollably that they lose control of their urine. I think it's a usual thing. It happens. So you don't see that and just say this patient has urinary incontinence. So there are questions that you ask to know that it's the control that is not there, and the patient cannot be able to control it. Saddle anesthesia. So in the buttocks, the skin there, the patient cannot feel touch or around the perineum or inner thighs. So saddle anesthesia or bowel and bladder incontinence. The patient cannot be able to control feces or urine, and then they have the saddle anesthesia. This is a red flag for urogenital disease. Then the yellow flag, fever, and chills. This shows signs of infection. So that infection possibly could come from the urogenital disease. And that is why it's a yellow flag, because you don't know whether this is infection in another system of the body entirely. So fatigue. Patients start to do some work and they get tired easily. Malaise, feel the body is weak, feel lazy. Anorexia, they have that fear of adding weight, and therefore it makes them not to eat. So ask about their meals, how much of food they eat and how many times they eat that. You see that they are afraid that they are going to. So usually it's for cosmetic reasons or for whatever reason, they have the fear to eat so that they don't gain weight. So you also have weight loss. So when you have these issues, you can see there is nothing directly related to the urogenital system, but it's a yellow flag. Then you now go ahead and begin to ask about the urination. You look for pain in the back. You look for other things that could help to see if there is a red flag. But these are yellow flags. You don't just refer immediately. You go ahead and do further assessments or observations. Then unilateral costovertebral tenderness. So between the spine and the ribs, that junction where the spine meets the ribs, when you palpate, it's tender and it's unilateral. So on one side, so costovertebral tenderness. Then low back flank is to the side, but in the back, but to the side. So even beyond the costovertebral region. Then inner thighs and leg. So all these areas, you have pain because these are areas that the urogenital system can refer pain to. Then change in color. So the urine changes color. There are a number of reasons why urine can change color. The food we eat, sometimes if you don't drink water for a long period and you just take water, urinate, you see the color changes. So that is why these are yellow flags, because you need to really find out, is it really an organic pathology that leads into these symptoms? So what they do is just to raise your suspicion that there is a problem, but you have to do further investigations before you begin to think of referring the patient. I don't know if Dr. Fine is with us. Dr. Fine Achubwe, are you here? Or maybe he has not joined us today. Okay, so that's okay. So change in color, consistency, smell. I was asking about Dr. Fine because this is something that we did, I remember, in one of the assignments in DPT with Michigan Flint. So that's why when I was reading it, I just remembered. And I remember I did not hear him speak. Usually when we do this, I hear him speak. Where is Mr. Anozie? Mr. Anozie, also, I've not heard you speak.
I'm here, sir.
Oh, you are here. Okay. Thank you. Yes, there are other few people that have been consistently contributing, but thank you to all of you. So change in color, consistency. So how consistent is it? So when you are urinating, when the patient is urinating, or when all of us are urinating, it continues to flow until the end. But in some patients, it starts to flow and then it stops, and then it continues to flow, it stops until at the end. Some may not even void completely because of that problem with the consistency. So it's important to ask all these questions. So the person that was asking question, what's the difference between pain coming from gallbladder, pain coming from the GIT? Now this is another system that refers pain to the lower back. So if you have pain in the lower back and you now want to differentiate whether that pain is coming from the GIT, the gallbladder, or the urogenital system, these issues are questions that you ask. So if the color changes and the consistency is abnormal, and smell. Some patients, while they are urinating, there is an odor. They can report that. Or reduced volume of urine. So maybe you whatever amount you discharge when you urinate, maybe now you are only discharging half of that, and therefore the volume has changed. Yes, Mr. Sunday, sorry, I didn't call your name, but I know we have a number of people that have not had their voice today. Mr. Sunday, thank you.
Thank you, sir. Thank you, Prof.
Well done. Yes, so these are some of the things that you look at. And very importantly, knowing what to ask and whether these things are there. So color is not difficult, but what is the color of urine? Patients know the color of their urine, and they will tell you it's abnormal. So, but what color really means it's abnormal? That's number one. For example, it's red and there's blood in it. It's a red flag. definitely is an abnormal that needs to be considered. But they said it's yellowish, darker than my usual urine. They say, when last did you take water before you noticed that, I was very busy since morning that I took 1 cup. I did not take again until 11 in the evening. And when I went, I drank water, I went to the toilet, I saw that, so, because these are the things that we're talking about. When Dr. Fine raised that question about, I said, well, maybe for you, you have done DPT, you understand these things, but it's not every PT that will know. How do I ask more questions so that I will know this is not abnormal for organic pathology, but it is abnormal for a change in situation, so that I will not refer. I will just say, okay, go take more water and then observe whether the color is still like that, and then we'll be able to know if we need to refer. So it's a yellow flag, it's not a red flag, because if you refer and the doctor asks those questions and they find out that it's not an organic pathology, they may feel you are not the right person to continue to refer our cases to them. So the change in color, consistency, if, for example, the patient has pain around the area of the urogenital system, and whenever they contract muscles around the area of urination, that indirectly elicits pain in another part of the body. And because of that, as they urinate, they try to hold it to reduce that elicitation of pain. You won't say that is a urogenital problem. And therefore, you need to ask questions. You need to confirm. Is it one that is as a result of the urogenital problem or not? It smells. There are a number of reasons why a urine may smell. So you need to find out. Is it really as a result of the urogenital system? Reduced volume, that also, because if there's anxiety or you become very busy and you don't take enough water, definitely the volume of the urine will not be as much as when you are taking water regularly. And therefore, we need to find out. So if all those questions are negative, and at the end of the day, we still have these symptoms, then we do more investigations to see when we'll have a red flag, and we refer. Change in size and shape of testicles or penis. So this is looking at the genital part. The other item is looking at the urological part. Then these are the genital part. So the testicles enlarge or reduce in size, that is a yellow flag. Or the penis itself reduce in size, that is, or increases, the size increases for whatever reason, that is a yellow flag. Change in smell. So it's not just the urine, because urine, we are dealing with the urological system. But with the genital system, we are looking at the ejaculate. So when someone ejaculates, does it smell? What will be able to know the volume, and if the volume increases or decreases just like the urine, then this will indicate a yellow flag. Or the consistency. So just like we did with the urine, the same thing applies to the ejaculate. So these are the areas of referral. And the areas of referral will depend on the part of the urological system. You have the renal, which is at the level of the kidney. You have the ureteral, which are the tubes that connect the kidney and the bladder. You have the bladder itself, and then you have the urethral, which is the tube that connects the bladder to the external part of the body. So the referral will depend on which part of the urogenital system we are dealing with. So at the level of the kidney, these are the areas that we have. So you have dark red. So dark red, which is posterior subcostal. So subcostal, below the costal level, and costovertebral region. So between the ribs and the vertebral region. So that area. Then you have the light red, which is at the low back. So this is the light red, which is at the low back. So around the flank. So when you say the flank, we are talking of either to this side or to this side. So it's not just at the low back. So it also goes to the side. It also goes to the side. So the flank. Then into the lower abdomen. So this is the lower abdomen. So this is from the back, and this is coming towards the lower abdomen. So lower abdominal quadrant, ipsilateral groin. So one side at the groin, you are going to have pain there also. So we're looking at the pain pattern, areas where the urogenital system can refer pain to. So remember, we talked about kidney pressure. So if the kidney is inflamed, because we are not talking of renal, so if the kidney is inflamed and it irritates the diaphragm or pressure the diaphragm, you are going to have pain in the ipsilateral shoulder. So meaning if the kidney on the left side is the one that is inflamed and it pressures the diaphragm on that side, you are going to have pain in the shoulder of the patient. Then we have uroteral. Remember, I said uroteral is the tube that connects the kidney to the bladder. So urine will move from the kidney and it goes to the bladder and it is stored in the bladder. And it is when the bladder is full or near full that we feel the urge to urinate. And then the urine will pass through the uroteral and then gets out through the penis to the toilet. So if you have the problem in the ureter, so this is the ureter, then you'll have costovertebral angle. So this is the costovertebral angle. Then you have the ipsilateral. So that side of the kidney, because the ureter is two, one from the right kidney to the bladder, another one from the left kidney to the bladder. But when we talk of the urethra, it's one. It just leaves the bladder, it goes to the penis or the female genital organ, and it is excreted, it goes out. So ipsilateral, so it can be ipsilateral, lower, so we see lower abdomen. So it's similar to what we saw in the kidney. So, but just observe the difference. With the kidney, it goes higher into the lower abdomen, but with the ureter, it is lower than that of the kidney. The kidney, we saw it up to this level, but with the ureter, we saw it around. So the location that the patient points to can also determine whether this is a kidney or a ureter affectation. Not that it matters to us, because whether it's kidney or it's ureter or it's urethra, in as much as it is an organic pathology in those areas, we are referring. I don't know if anyone is aware of any, I believe there should be exercises or any intervention that could be done to help muscles. I think those in women's health and in urology would be very familiar with those things. But what I'm trying to ask is if there is anything that can be done when it extends to the level of the ureter itself, the ureter itself. So ipsilateral lower abdomen, so it's ipsilateral and it's lower abdomen. Upper thighs, you can see the thighs, and then the labium and the testis. So the testis and the labium, you have pain around there, and it is still uroteral. Then for the bladder, so the bladder goes together with the ureter. You have suprapubic, and then you have low back, which is the dark red, primary pain center. So primarily this is where you have the pain when it is the bladder or the ureter. And then you have the light red, which is on the flank. This is referred pain. So when you have pain in the bladder, the pain is felt around here, but the one that's referred will extend to the flanks. Then you have the prostate. Now looking at the genital. So when there's a problem in the prostate, you have lower abdomen. So lower abdomen, suprapubic. So the suprapubic region. Then you have the light red, which is referred to the low back. You have the low back, the scrotum, testis, inner thighs. So inner thighs, the testis or scrotum. It's a sacrum. This is the sacrum. So you have the lower back, the sacrum. So all these areas are areas of referred pain from prostate. So patients that have prostate problem, many of them will come to you with back pain. And unless you know of this link, you may be treating that back pain without really asking them questions about the prostate. I remember someone mentioned something like this on, was it Saturday or Wednesday, that they had a patient, I think, was it Akin? Yes, someone, maybe Akin, mentioned that they had a patient and they asked questions, and later there was a diagnosis of prostate cancer or something like that. So very important when you have patients with pain in these areas that you think of the prostate. So this is it: the kidney, the ureter, the bladder, and the urethra. Yes. So any observations, questions, comments? Yes. Igwebuke, Ifeanyi. Yes, Ifeanyi, I think you are one of those that have been making comments in the past lectures. Go ahead, please.
Yeah, good morning, Prof. Hello.
Hello, yes, go ahead, Mr. Ifeanyi. We can hear you.
Okay, yeah, good morning, Prof. Yeah, that's Honesty Fef, the one you know.
Yes, honesty, yes.
Yeah. Is that right, sir? Thank you, sir. Thank you. Thank you so much. Despite you mentioned being, not being able to sleep very well last night, and you are still up. So we appreciate that. Thank you so much, sir. Yeah, what I want to ask, or is a simple question. You made mention about saddle anesthesia. I don't know if you can go back to that slide.
Okay.
Yes, saddle anesthesia. Let me see that slide.
This is the one.
Yeah. Yes. Saddle anesthesia. Okay, one of the things that's one might see and begin to think in that direction. And I want to ask, and also subsequently, from your even last slide, you also, when you are talking about urethra and bladder, referring pain to the lower back. And I think if you look at the mark, where you printed or you marked, it looks like from S1 or S2 around that region of the lower back. Now, I want to ask, when you have a patient with cord complaint, like cauda,
think, is it your network?
a loss of sensation around that anorectal region. Okay. Yeah. So how can we match the two? Is there any other thing that want by you? Because assuming that you have a patient with to present with that saddle anesthesia, and you are considering looking at the left fracs for urinogenital disease. And also looking at this, like I mentioned in cauda-equina, is there any other some of the other things that one can you look at or see and begin to
say that there is a red flag?
Yes.
You don't need any other thing. When you see these two things, for example, I said when you see blood in urine, that alone is a red flag. Just send. Remember, I think, was it in pulmonary that we said if a patient coughs and the sputum is green, that on its own is a red flag you refer, isn't it? Because there are some things that just one thing will indicate an organic pathology. So with this, I thought maybe we're even trying to refer to how do you assess to know what level it is. So I quickly just Googled the dermatomes. So you know when you do, yes, okay. Okay. Go ahead, I'm listening.
No, you just mentioned how to assess properly because
yes,
I think it's also an issue.
Okay, it's also an issue. Yes, exactly. So you know the patient will now report that when you sit, there are times that you feel irritation and you now shift. Sometimes you keep shifting while you are sitting because of the skin feeling the irritation of what you have sat on. Now, when you sit on something that has cushion, you spend longer time before you change or you adjust as you sit. But when you sit on something that's bare and hard, because of that sensation on your skin, you keep adjusting and keep. So these are some of the things that patients will feel as a symptom. Then for you, as a sign that you want to test, you now turn them around, expose, and then you use something like this as the dermatomes. So you are now using cotton wool to touch the areas, and then you say, do you feel? They say yes or no, or tell me when you feel yes or no, meaning there is no sensation there. So these are almost around L2, you have S3, S4. These are the areas of sensation around that saddle area that we are talking about. So you can see that. So I thought that's what you are referring to, but I think that's also is important because we need to know what to assess or what to ask the patient to report for us to be able to know if that problem is there. Sorry, I hope I've responded correctly. If not, please just let me know what areas we need to discuss further.
Yes, okay. Yes, sir. You responded well. I think I've gotten a clear picture about what I wanted to know. Yeah, thank you so much.
Thank you. Well done. Yes, Ngozi Ikwemi. So, Honesty, can you lower the hand, please? Good, thank you.
Thank you so much, Prof. And good day, everyone.
Thank you.
So my question is on when you talked about the red flags for genital diseases. So shouldn't we consider that we have therapy approaches to urinary incontinence? Or are we trying to group it? You must see cervical sign pain and urinary incontinence.
Yes, actually.
What if it
Okay. Now, what that means, usually when we say there is a yellow flag, we mean a yellow flag for that particular system. You know, if you have an injury in the brain, it can lead into urinary incontinence. And therefore, it's a red flag for a neurological system, not for the urogenital system itself, which is not the brain. It's a system on its own, urogenital system. If you have spinal cord injury, you are going to have a problem in the urogenital system. Now, what we are talking about is that we are looking at the source, who is going to treat. If you are assessing the neurological system and there is an injury in the brain that leads into incontinence, you are not going to have a urologist treating the patient. The urologist will continue to do whatever they will do. The source of the problem will not go. There must be a referral to a neurologist. So what we are talking about now as a red flag for urological system, because you'll not have a brain injury that affects the area that controls urination. And then you'll now be having low back pain. They don't go together. Unless if the low back pain is a musculoskeletal problem that is local at the musculoskeletal area. So meaning you have two different conditions. So what this is saying as a red flag for urological system is that when you have the primary source of the problem, maybe an infection or an injury to the urological system itself, it refers pain to the low back. And therefore, when you see the two together, you cannot be thinking of a red flag for neurological system. You'll be thinking of a red flag for the urological system. And if in your organization, you can refer directly to a specialist, what specialist will you refer to? You will not refer to a neurologist. You refer to a urologist. And this is what the issue is all about. But if in your organization, you only refer to a physician, then the moment you see someone cannot control urine, it's a red flag, and you refer to the physician. It is up to the physician now to now do further analysis and evaluation to say that this is coming from the neurological system, let me refer to a neurologist, or this is coming to the from the urological system, let me refer to the urologist. So I hope this is clear.
Thank you so much. Well answered. Thank you so much.
Thank you. Thanks. Okay, so let me see if there are messages on the chat forum. Have seen the red flag sign in patient with prostate cancer. Yes, wonderful. Oh, maybe it was you that mentioned. I think I can also mention, or maybe this is something new that you are reporting to us. That's wonderful. Yes, there are red flags in the prostate cancer. Very important for us to take note of it. If not, we'll just be treating the back and it will not be at the back. You said we lost you. Okay, sorry. Can you let me know where you lost me so that I can be able to get back there?
It was when the first presenter was talking at the the audio.
Okay, that's fine. Yes, I remember myself. I couldn't hear. So okay, so that's great. I think we have responded to all. So let me go back to the slides. Okay, Mr. Sunday, just show your hand.
Oh, thank you, sir.
Yes, thank you.
Thank you, sir. I really appreciate you for this lecture. I actually enjoy it from the time I've joined. But I observed that you made mention of, if there's a increase in temperature, that is is it a yellow flag or a red flag? That is one question. Because there are some situations. I have a patient sometimes, even in recent time, that when we're managing, we are now observed that the temperature consistently increasing, and it was not subsiding. I call at a particular time, I have to, even incidentally, the patient has happened to be a relative of a medical doctor that even holds another hospital. But I was managing his patient. Now, when I observed it, I was trying to call his attention that, sir, these patients temperature has been likelihood of infection based on some people.
We've lost you, Mr. Sanding.
Yes. So I was observing it, but the doctor, I think, hello, sir.
Yes, I'm here. Hello? Your network possibly is not good, but I can hear you now.
It's not. Yes, I said the doctor was keep on telling me that I should continue to teach. I said no. I said there is something I'm suspecting. This temperature has been continuing consistent for almost 3 days, and it was not subsiding. And my suspicion was that there's likelihood of infection. I asked questions, and I asked him, has the patient placed on any antibiotics or been treated for malaria or whatever? That was what I was suspecting. Then, if it's not, I will suggest that let us run some tests and find out whether there's any likelihood of infection. But the doctor was not seen to see what I was observing. Now, with what you just presented, is that not a red flag in itself? Because sometimes we physiotherapy really find out a challenge that, okay, when patient is running temperature and all that, it may not be our domain to actually further investigate, but we can make referral, which I have actually done several times. Is it not a red flag? Do we continue to treat if you are taking it to be yellow flag? Would that not be a problem? So that is just, I just wanted to put more light, sir. Thank you.
Thank you. Actually, when I talked about fever, it was under yellow flags for screening urogenital diseases. And it says fever, chills, fatigue, malaise, anorexia, weight loss, all this put together, all of them are yellow flags for urogenital system. And remember, I was saying, you can even see that there is nothing there that shows anything peculiar to the urogenital system itself. Because it was later that we saw things like color, consistency, smell, and other things that can come in together with this to now indicate that this is even referring to the urogenital system. But the reason why this is a yellow flag, whenever you have a rise in temperature, but that's not the only thing that you are looking at. You are looking at it together with chills and fatigue and other things. They form the yellow flag. Now, why is it a yellow flag, not a red flag? Because if you look at reasons why temperature can rise, it can be infection, it could be medication. It could be because of the medication that the patient is taking that the temperature rises. So if, for example, the doctor knows that the medication they have given to the patient can raise the temperature, if you send the patient to them, you have not asked about the medication and you have not checked what the side effects of the medication are, or maybe there are two medications, each will not raise the temperature, but the interaction effect of the two will raise the temperature. These are the things that we need to clear before we refer. And that is exactly what Dr. Fan Attribute was telling us that time, that the doctors are saying we shouldn't refer to them. We need to understand when to refer and when not to refer. Because if it is the medication that is raising the temperature, not infection, and that medication that has been given maybe is the best for the patient, the alternative may give him even a worse, worse side effect. Then the doctor will say, look, this is what I'm going to maintain. I'm not going to change that. Now, but where you are going to now go to the doctor is if you have a particular intervention you want to give. For example, physical activity, exercise, because exercise increases temperature itself. This is a patient that is on medication that increases temperature. Now the medication and exercise. And now the patient moved from their village, which is very cold, to the urban area that is very, very hot at the moment. So the hospital does not have AC. Your gym does not have AC. The patient is on medication that increases temperature. The exercise you want to give increases temperature. The patient has come from a different environment to an environment where naturally the temperature will go up even more than the person that is living there. This is something that you can present to the doctor. Well, I have this case. I know the patient is on this medication that may be the reason why his temperature is up. He has come from so environment to this environment. That also will contribute towards increase in temperature. The intervention I'm going to give him to rehabilitate him will require exercises that also are known to increase temperature. Please, I'm just coming to have a discussion. How could we sort out this? At what point does he take the drug? At what point does his temperature increase as a result of the drug? Now, when should I come in with my exercise? So this is consultation. Or maybe, is it possible to change the drug so that he takes one that does not increase the temperature for the purpose of me giving him the interventions that I need, and then later he can go back to that drug. You sit with the medical, you discuss that. But just referring, because of rise in temperature, I say just, please, this may seem an organic pathology. The doctor is going to return back to you, of course. One doctor may explain to you, another may not explain to you. They will just say, please, this is not a case that needs to come back to me. Just continue to treat. And that is why we are doing this, so that we understand all the implications of the information we collect from patients and how we can interpret it to even know whether it needs to go to them or it doesn't need to go to them. Now, when you are doing your clerking, you have drug history. You take the drug history. What drug do they take? What are the side effects of the drugs? You will get information from there. What sorts of physical activities do? They do activities that increase their temperature. What sort of environment do they live in? Have they moved from another environment to another environment? All these things will help us to know what reasons, apart from infections, that could bring about a rise in temperature. So I hope that helps too.
Sir, hello, sir.
Yes, yes, sir.
Like the patient I put as a example, they eventually find out that the patient has infection.
Okay.
They eventually find out when I was insisting that I was not going to treat, that what I was suspecting, because we are always together with the doctor while treating the patients. So when I was insisting, they eventually went to a run test and they found out the patient had infection.
Has infection. Okay, let me ask you this question. When you were referring, apart from the fact that the patient has fever and I suspect infection, did you add any other information? Anyway, let me just respond. Now, it's possible there is fever. Sorry, there is infection. You see only fever, and later you realize there's infection. Now, if in the first place you just say fever, and they return the patient to you, what I'm trying now to say is that since it could be two things, it could be the fever, it may not be the fever. If you follow up the question, the observations about fever, you see, apart from fever, there are chills, there is this, there is that, and there are some symptoms of the particular system where the infection is coming from. You will have a more holistic information that the doctor will not reject. That's number one. Number two, you would have sent the patient to the appropriate specialist, because if it's a neurologist, he might not be thinking of issues that have to do with the urological system, for example. But if you had sent it to the urologist, he will ask relevant questions to know that the infection is coming from that particular system. So what I'm trying to say is that we can't refer a patient and just say this patient has fever. Even if there is infection, it is going to cause some bureaucratic challenges that before the infection is realized, there will be back and forth. But right from the beginning, let's put together an analysis and evaluation that will be hard to reject. Because if you say, I have A, B, C, D, all these point towards an infection, including the fever, and then other things, the doctor is more likely to accept it than if you just say fever. So even if there is infection, you say fever, they will return to you. You will have to now do other investigations, and then you will now try to convince them with something beyond the fever alone before they accept it and they do the test that will bring out the fever in the patient. So I think it's still important that our interpretation, our evaluation should go beyond just looking at one system, especially not system, a symptom, especially if that one symptom naturally does not become a red flag. So that is it. So fever is not a red flag on its own. That's in a nutshell what I'm trying to say. Fever is not a red flag on its own. It has to come with other symptoms put together that will give indication of fever, which is a red flag. Now, this is different from the one we talked about earlier, that if you have blood in urine, that on its own is a red flag. If you have sputum that is very green, that shows an indication, even that you'll see that it comes with cough or with dyspnea or what have you. But if you have it's green. Even that, there are some questions that someone was saying. I can't remember, maybe it was even you that was saying, no, maybe I know someone was saying the environment could influence the color of the sputum. And therefore, it's still not regarded as a red flag. Let's do some more investigations so that we confirm is the infection that leads into that. So we need to be careful. When it is a yellow flag, you must have a follow-up observation or investigation. But if it is a red flag, you can refer immediately and you will indicate why you think it's a red flag, that there is a very big suspicion that there is an organic pathology. Yes. Anyone wants to speak before we go back to the slides?
Thank you very much, Prof. You just mentioned a lot of things while you were explaining, because I was raising my hand and I was bringing it down because you touched all the areas. I just wanted to mention, because the last speaker was, I understood that there was a reluctance by the doctor to, listen to that advice, as it were. But the reason could have been because of the communication, and just mentioning as fever, just like you said, as a sign, is not enough for the doctor to have acted at that point, because there are other factors they are considering at the point. So I'm sure before they were able to establish that there was an infection, there were other things that they saw, and they ran some tests. And so as a physiotherapist, if we have to see patients who come in with that, it's always good to probe further so that our write-up will be more detailed and more explanatory then, and to be able to convince the professionals that we are communicating with. Most times for yellow flags, if you feel that, from my own experience, if you see that and it's going to affect your own treatment as a physiotherapist, I think it's not a specialist referral that you are doing for a yellow flag. You could just make referral to the physician for a yellow flag. But if it's a red flag, then you could be, if your jurisdiction allows you to refer to a specialist, then you could just go to a specialist. But usually where I work, you have to go to the GP, then the GP could escalate further. Yeah. But thank you very much, sir.
Okay, thank you. Thanks a lot. Well done. Thank you to all of you. So let's go back to the slide. Just let me know at what point we'll need to take a break, either 12:30 or 1. So at some point, just let me know, maybe even if it is through the chat forum.
Yeah, I think 12:30 is okay, at least so that you can also get some rest yourself before you continue.
Thanks so much. I appreciate that. Yes, someone also says 12:30. Okay, so that's okay. Okay, I think we stopped after urogenital system, I think. I don't think we have done endocrine system. Yes, so it's endocrine system. Let's look at endocrine system. Remember when we did, I don't think we have done human movement system. Dr. Samani, are you with us?
Yes, sir, I'm there.
Please, can you find out when we are going to do human movement system?
Okay.
I'm going to explain some things here about human movement system. I think I did that also.
Okay.
I can't remember which lecture we had. Maybe it was clinical reasoning that I discussed the issue of physical diagnosis. Physical diagnosis. And I was explaining what the human movement system is. So I said human movement system is a system of systems. So we have systems of the body that come together to work to bring about movement by the individual.
It will be in July. Ending July.
Okay, it will be in July. Is it in on Saturday or Wednesday?
Okay, Wednesday, Thursday. All in the
Wednesday,
evening.
Thursday. In the evening.
31st.
Okay. Okay. July is far from now, but it's okay. It's all right. Thank you. Thank you. Yes, so I was trying to explain the human movement system. So you have the musculoskeletal system because it's the effector. And it's a system on its own, but it's the effector in the human movement system because it is muscles that contract and bring about movement in a joint through bones moving. So the muscles will influence the bone to move, and the bone will move at the joints, and then there will be movement. So with the lungs and the heart, there's also movement because it's the musculature that contract to bring about the movement. So the musculoskeletal system is the effector. It is one component of the human movement system. But they don't work on their own. Something influences the muscles and bones and joints to move. And the influencer or the controller is the brain or the nervous system. And therefore, the neurological system is seen as the controller of the movement, while the musculoskeletal system is the effector. It is the one that does the movement. But the brain is the one that even decides whether to move or not and gives the impulses, sends the impulses to the muscles and asks them to contract. But without oxygen and other nutrients that the brain and the muscles and the bones need to move, the movement will not take place. And therefore, the pulmonary system is also part of the system as a support system to the brain or the neurological system and the musculoskeletal system. So the pulmonary system is the one that brings in oxygen into the lungs. But even though there's oxygen inside the lungs, if the cardiovascular system does not take that oxygen, if the cardiovascular system does not go to the GIT and pick nutrients that are required and take it to the brain and the muscles, movement is not going to take place. And that is why the pulmonary system and the cardiovascular system are part of the human movement system. But with all these systems functioning well on their own, if the endocrine system is defective, you are still not going to have movement. Because if you need to regulate glucose in the body, you will need the endocrine system. We talked of the pancreas earlier. We also talked of the regulation of fat through the liver producing the bile and the biliary system taking it to the gallbladder. And when it's needed, it's sent from the gallbladder through the biliary system and it goes into the small intestine. This is an endocrine thing. People will have diabetes, they will have problem with movement. And that is why, to us, the endocrine system is part of the human movement system, but we also do systems review because mostly it is going to be an organic pathology that affects it and that it requires referral. So what am I saying here? There may be some systems of the body that may not contribute directly to movement, and that the organic pathology, we are referring to the physician for the fact that the patient needs to get attention, even though the attention they get may not affect directly or indirectly the movement of the patient, which is our domain, which is our interest. But there are some instances that the system of the body, we are referring for organic pathology related issues that we want the doctor to look at it and solve the problem of the organic pathology so that the way it affects the movement of the patient and what is relevant to us will be sorted so that we can be able to help the patient to move properly. So I'm just giving this background information so that we'll be able to understand from the perspective of a physiotherapist how it can affect the movement of the patient because of the human movement system. Remember, I also discussed the issue of kinesiopathological model and pathokinesiological model. So if you have a movement-related problem, such as repetitive motion or sustained alignment, and as a result of that, a pathology sets in, the physiotherapist sees the patient, takes care of the movement-related problem, and then refer the patient to a physician that is going to take care of the secondary pathology that set in as a result of the movement-related problem. But if you have the pathokinesiological model, where the organic pathology sets in, so we have a patient that has diabetes because of a problem in the regulation of the substances that control the sugar level in the body. This is a pathology. The patient's movement is normal. But as a result of the pathology, the patient now will begin to have movement-related disorders. The physician will see the patient first, or the endocrinologist, or whoever it is that's seeing the patient, will treat the organic pathology, and then we as physiotherapists will come in to now treat the movement-related problems. Treating the movement-related problems without taking care of the organic pathology will mean that we'll continue to treat without discharge, because the source of the problem has not been eliminated, and therefore our treatment will not end until the source is taken care of. So I think these things will help us to be able to focus on giving the patient treatment that
carry your books,
will end.
carrying the place. How can you read in this?
Yes, Chooks, Mr. Chooks, yeah, okay, thank you. Yes, so I hope that's clear. So let's look at screening for endocrine diseases. What are the red flags? When the patient is confused, so confusion, we are familiar with that. We know what we see in the patient to be able to know that the patient is confused. Lethargic, feeling lazy, don't want to do movement. Changes in mental function. So their attention level, their ability to comprehend things, their ability to remember things. So that is why we do the TPP, say oriented in time, person, and place. So we do all that, and we see that the patient has changes in mental function or level of consciousness. So all this, then profuse sweating. There is AC, you are feeling a little bit cold, but the patient is sweating. Or the patient reports sweating that is abnormal. In the past, I would sit in my room, I will not sweat, but now I sweat profusely. Then signs of ketoacidosis, which is fruity smelling in the mouth. So the patient smells like there is fruit in the mouth, but there is no fruit. They have nausea or vomiting. Very important to always ask about nausea and vomiting. Then deep breathing. They breathe deeply. So all this put together have an indication that there may be diabetes or that the patient has hypoglycemia. So this is a red flag for referral either to a physician or to an endocrinologist. Then signs of potassium depletion in a patient using non-potassium sparing diuretics. So if there's potassium, you understand why you have those symptoms. But if they are using non-potassium sparing diuretics and the patient reports muscle weakness, so there is weakness, and you'll start thinking of the neurological system. And this is what I was saying earlier. It's a red flag for neurological system, but it could be a red flag for an endocrine system, seeing muscle weakness. So what do you do to know that it is a neurological system or is an endocrine system? These other symptoms that will come together to now form what is called diagnostic criteria will not be the right word to use, because diagnostic criteria is what helps us to have a diagnosis. So this is not helping us to have a diagnosis, but we'll see referral criteria maybe. But this is a criteria to say muscle weakness alone does not give indication of endocrine involvement. What other things give indication of endocrine involvement? Weakness and cramping. And we know cramping is like a muscle pull, involuntary muscle contraction that's painful. So fatigue, you start to walk, you get tired, and you stop. And this is unusual because I can walk 2 kilometers without getting tired. I now walk half a kilometer, I get tired, I have to sit down and rest. Cardiac arrhythmias. So the rate of beating of the heart is abnormal, either too high or too low. The patient has nausea. Can you see nausea and vomiting with endocrine system coming in each of the red flags? Even the next one, I can see at the end nausea and vomiting. So very important, if you have any suspicion of endocrine disease or system problem, that you ask about nausea and vomiting. Then you have dehydration. The patient will drink and they will still have their lips dry or their skin dry. Then signs of thyroid storm, tachycardia, or I don't know whether you call it tachycardia. So the rate of heartbeat increases abnormally. Elevated core body temperature. So can you see that issue of temperature, body temperature? So that alone is not serving as a red flag, but when you have increased beating of the heart, the rate of beating of the heart, restlessness, agitation. So all these ones, I think, it's clear. We know how to find out that the patient is restless, they are agitated, they have abdominal pain, nausea, vomiting. All put together, red flag, refer to the endocrinologist. Unexplained fever in patients taking corticosteroids. This may be an indication of infection. So can you see, it's not just the fever, but it cannot be explained. Look at the environmental factors, didn't contribute. You look at their, okay, now medication is there. So medication, patients taking corticosteroids. So you think of an infection and you can refer. Palpable nodules in supraclavicular area. So you know the supraclavicular area, if you palpate it, and that's why it's important for us to know where those lymph nodes are, so that we'll be able to, and also we need to know what should be the feeling when we touch those areas where they are, so that if there is any feeling that is different from what that place should have, we'll be able to now suspect that there is a problem when we palpate those places. So supraclavicular area, and then the scalene triangle. You remember, I think when we did in anatomy, brachial plexus, we talked about the scalene triangle around the neck area where the brachial plexus passes through. So, and then the patient has new onset hoarseness. So there's hoarseness in the voice and it's new. There are some people that naturally, they have a hoarse voice, but someone that does not have a hoarse voice and they speak and you feel that hoarseness in the voice, that also adds to the symptoms that gives a red flag for endocrine system. Then hemoptysis. There is blood in the sputum, or when they spit, there is blood. And then you take their BP, the blood pressure is higher. So I don't think there's any of these issues that will be a problem. Maybe when we stop, I'm going to get the picture of the scalene triangle and maybe the subclavicular area. So when you palpate it and you feel an abnormal mass there, as you call palpable nodules, then you'll be able to add it to this suspicion of a red flag for endocrine system. Multiple eruptive xanthoma. So I think I'm going to also get the picture for this. This is a skin condition caused by high lipid in the blood. So if you have high lipid, and that's why it's yeah, sorry, can you see the slides? Lost connection. I had to log back in. Can you see my slide?
Yes.
Okay,
Yes,
okay, wonderful.
we are.
Okay, thank you very much. Thank you. So
Yes,
uncontrolled glycemia. Yes, so when you have uncontrolled glycemia, that's when you see these multiple eruptive xanthomas on extensor tendons of patients. So usually in diabetes. Remember, we saw in the earlier slides hypoglycemia. So you have diabetes when you have confusion, lethargy, changes in mental function, profuse sweating, and signs of ketoacidosis. It shows hypoglycemia. But for uncontrolled glycemia, you have the multiple eruptive xanthomas. Very important to know what the readings for the lipid profile is. As I've mentioned earlier, high and low, and then the total cholesterol. So high density and low density lipoproteins and the total cholesterol. So signs of fluid loss or dehydration in patients on diuretics. So they are on diuretics. So can you see how important it is for us to know drugs? I don't think the knowledge of drugs is, our knowledge of drugs is up to the level that it should be. And something is coming that if we are not ready, we'll be seen as not being able to take up the responsibility. I remember I've been drawn into to serve as a member of a committee for developing national policy on prescription and dispensing in Nigeria. So very soon the policy will be ready. And one of the things that is in that policy is what is obtainable in the UK. That issue of task shifting and task sharing, where a physiotherapist can be empowered to prescribe some forms of drug, not all drugs, not all. So we need the knowledge of drugs for the purpose of knowing how the effect of the drug, side effect or interaction effect of drugs could affect the treatment of the patients that we give. We saw an example earlier with the issue of fever, that some drugs could lead into increase in fever, and that could affect the exercises we give because the exercises also lead into increase in fever, in temperature of the body. Sometimes we need to give the drugs, we need to know what drugs are taken and their effect. For example, I want to mobilize the limbs, and the patient is on levodopa. And there is what is called on and off levodopa. That is a drug for Parkinson's disease. It gives the system or the basal ganglia, the dopamine that is required to help in its function. And that is what helps with the issue of bradykinesia and rigidity and tremor. So at the time the patient is on the drug, so meaning the effect of the drug is there, they have relief of the rigidity. And therefore you can be able to do your exercises and other rehabilitations that help the patient to learn or to be able to do activities of daily living. But when the patient comes to you off the drug, meaning the effect of the drug is not in the system, it will be very difficult to even move the joints, not to talk of instructing the patient to do some activities of daily living. And therefore, if I am empowered to prescribe drugs, for example, in a patient that has severe spasticity and there is need for a botulinum injection, I should be able to give the prescription and administer the injection. So these are the things that they do in the UK that we don't do here. You have to always refer back. They give them the drugs, they now come back, you treat them. So this might come our way in the nearest future. Let's not broadcast this because it is still at the stage of development, the policy. And I'm not seeing any challenges. Everyone is accepting it, all the groups that are in the committee. And I believe at some point it may come out. It's going to help our practice, not because we are adding tasks, but because it's going to reduce the bureaucracies where we have to refer the patient, they will go get the drug, and then they will come back. We can be able to combine doing our own thing and prescribing the drug. So if we don't understand the drugs, we don't know them, we don't know their side effects, we don't know their interaction effects, it's going to be very difficult for us to be given that task and we take it properly without disappointing those that give it to us. So I want to encourage us. Let's go back and begin to understand drugs. Let's understand their side effects. Let's understand their interaction effects. But in anticipation of what the future will bring, let us also begin to understand what their function is, what they do to the system, and how they help solve the problems of symptoms and signs in patients. And in what patient is it that you can apply them, in what patient is it that you cannot prescribe them, and things like that. Very important that we start preparing ourselves for the future. Then signs of fluid loss or dehydration. So a patient is on diuretics and they have dehydration. So your pituitary gland releases vasopressin to influence kidneys to conserve water. So in a patient that is on diuretic, so it's important to know that what drug the patient is on. So whenever the patient says, I'm on diuretic, and then you see signs of dehydration, it's a red flag, refer the patient. Recurrent arthritic symptoms. So the patient has symptoms of arthritis, they come, they go. And this is a patient with gout taking urate lowering drugs. So they have gout and they are taking urate lowering drugs, but they have recurrent arthritic symptoms. It's a red flag. Refer the patient. So these are some of the yellow flags. So what do you see that you don't refer, but you do further investigations? I'll quickly go through because it's already 12:30. So can you see what I was saying earlier, I think last week, that risk factors alone don't form red flags. Risk factors alone don't form red flags. Sofiat, I think it could be you that, Sofiat Bishola, please can you unmute yourself? Mr. Efien, yeah, I've seen your hand. Maybe at the end of this slide, if it is a new hand, I will ask you to speak. So past medical history of endocrine or metabolic disease. So if someone has had an endocrine disease or a metabolic disease, maybe it has been cured, it's no more there now. But when the patient came, they reported they had past medical history. of endocrine or metabolic disease, always do a follow-up observations and investigations to see if there will be a red flag for endocrine disease. Bilateral carpal tunnel syndrome. So when you have proximal muscle weakness, okay, so you have bilateral carpal tunnel syndrome on both sides. So you need to go back, look at carpal tunnel syndrome and know how to identify that it's there in the patient. Very important. Just saying it, you will see the patient, you wouldn't know what you are looking for. Bilateral carpal tunnel syndrome, proximal muscle weakness. Now, this is where, if you remember in clinical reasoning, we mentioned something that shows expertise. Who can remember what we mentioned, that people will be used semantic qualifiers. Semantic qualifiers. So you are not talking about proximal muscle weakness, and you are using that semantic qualifier in your interpretation. It's not just any weakness. So a generalist is looking at weakness, but you as an expert that wants to evaluate, you are looking at the muscle weakness that it is in the proximal area. And this is what I will use to add to this to see a yellow flag for endocrine disease. If I see it in the distal area, even though there's bilateral carpal tunnel syndrome, I might not be thinking of endocrine disease. So it's in proximal muscle weakness. Shoulder periarthritis. So it's calcific periarthritis or calcium crystal disease. So you need to also go back and we look at what are those symptoms of shoulder periarthritis as different from another type of arthritis that is not through calcium crystal deposition. So this put together gives also, it's just a yellow flag. We need to do further investigations for us to refer. Long-term use of corticosteroids. So you need to know, has this patient been on corticosteroids for long? And therefore, it goes beyond just saying what drugs do you take. It's important to ask, how long have you been taking these drugs? So it shows possibility of Cushing syndrome, excess cortisol, a response to stress, glucose metabolism. These are all endocrine tissue issues. Trigger points not relieved by therapy. So usually if you have hypothyroidism, will lead to pain that when you use trigger. So why is it not a red flag? Because trigger points not relieved by therapy, it could be a referred pain from another organ. And therefore you need to now go ahead and look at other symptoms of hypothyroidism to be able to know that it is the cause of that issue that is not being relieved by trigger therapy. Metabolic alkalosis, when there is lack of chloride, you see muscle fasciculation. Remember earlier we talked about cramping. It's like a muscle contraction that's painful, involuntary, sudden. It comes and you feel pain in the muscle, but it's just at that point of contraction. Muscle fasciculation, I've given an example of this, say when you have polio or anything that affects the anterior horn cells. So in fact, it's one of the things that differentiate anterior horn cell affectation and peripheral motor nerve affectation, because all of them will come with lower motor neuron presentation. There will be no hyperreflexia. There will be no spasticity. There will maybe atrophy. But what differentiates between the anterior horn cells and the motor nerve in the periphery will be that fasciculation. In anterior horn cell, you will see the fasciculation. And it's just a small involuntary movement that you see in the muscles, just like when butchers peel the skin of a ram or a cow, you see the muscle continue to have that fasciculation. So cramping, I've explained cramping. So antacid use, when patients use antacid, so it's important also to know if patients use antacid and then whether you see that fasciculation and cramping. So it's lack of chloride. that causes that. It's an organic pathology, but you need to ask further before there is need for referral. Muscle weakness and fatigue in patients on diuretics. So this also is a yellow flag. Arthralgias, hand pain, and muscle weakness. This also is a yellow flag. Yes, so is there any hands up? I know this is already 12:35. Yes, honesty. Go ahead. Let's if
All
it
right,
is an
thank you, Prof. Thank you, sir. Yeah, what I want to, say or chip in is that concerning what you mentioned about the policy, I mean is it the group where you we
prescription and
adopted it?
dispensing policy. Yes.
Yeah, the board. So I think, before you forgot, I think there might be a need because most of us did pharmacology in final year as a course. Okay, but the truth is, I don't think it was a complete one. And the second, they say practice makes perfect because we don't usually prescribe and all that. People tend to overlook it anyway. So I think it will be good to include it in this year's workshop. Series of pharmacology lectures, workshop. Even if it's up to 10 different sections, that's okay. But people need to be grounded again. So that's what I want to chip in. Thank you.
Okay. Thank you very much. Dr. Jibril, please take note of that. Remember last time we talked about muscle functions, relating it to activities of daily living. That's very important one because when we look at the human movement system, you cannot understand movement without knowing muscle and how they get involved in activities of daily living. That's number one. This also is very, very important. Take note of it so that we can have a workshop on drugs, their functions, their what conditions are they used, what symptoms and signs are they used, and also what are their side effects, what are their interaction effects, and how that can influence the rehabilitation of patients or our treatments. Yes, so please take note of that. Mr. Sunday.
Thank you, sir. I want to appreciate you for this beautiful paper presentation. I think this issue of policy, in a way, presently, we are still having some challenges as regards to some of our undergraduate students that are running posting even at the list of radiology. The feedback we are getting from them now is that they were not actually ready to give them some details about studying, reading, radiology, or whatever. Able to teach them. Some of the doctors, they feel reluctant in exposing them. They will say they don't need it. But there's some effort that they made concerning our persistence and then continuous going to meet them. But the feedback has not been encouraging. I don't know what the board will do in ensuring that our students have robust exposure as regards to this area. Now that we are even moving to drugs, which we know quite well that most of our graduates, a lot of us have not been able to get the whole contents of getting exposure to other drug interactions, reactions, combinations, and the likes. And if this policy is able to skate through, I think the MRTB, the board has to do a lot of work for them to be able to ensure that the actual, lectures on them are actually exposing us to them so that our people will be able to have the full understanding of what we are expected, and those stakeholders that are involved, that I need to actually be teaching them, we know that it is it's their responsibility to give us all that it requires, as long as the law will back it up for us. Thank you, sir.
All right. Thank you very much. I did DPT with Michigan Flint University, as I said it earlier. And some of those courses that you mentioned were not taught by medical doctors or pharmacologists, what have you. They were physiotherapists. Because in the United States, DPT is something very serious. Everyone that will practice must have a DPT. And for a very long time, they had been doing DPT. Now they have residency program. In fact, they even have specializations and sub-specializations that they would say you have a fellowship or you did residence fellowship, and what was it that they call the sub-specialization? They have moved far. And therefore, they take those courses. And I'll tell you why it's important for us to take the courses. Someone, a pharmacologist, a pharmacist, or whoever it is that wants to teach us about drug, will teach us about drug from the perspective of their profession. They don't know our profession. They don't know the treatments we give. They don't know the influence of drugs on what we do, because what we do is not in their curriculum. Recently, someone called me and said they want medical doctors to start going to that department. I said, very welcome idea. Many physiotherapists are afraid. I said, you are afraid that someone will come and take your responsibility because you have not advanced yourself. Advance yourself and see how people will now be coming to you for consultation rather than coming to take up your job. Let them come. You educate them. This is what when you are referring patients, this is the way you refer to us. Talk to them about human movement system. Well, that's why I really wanted, maybe Dr. Jules Samani will push that human movement system back. Because when we do that, I presented this, I think in Lagos and in Abuja 2 years ago during World Physiotherapy Day. CMDs were there. And when I was speaking about the human movement system and physical diagnosis and impairment, movement impairment classification, they were just looking at the slides and they were shaking their heads, yes. And at the end, I said, look, medical doctors are not trying to fight you. It's because they also have the fear that you are going to take away their job because you are making medical diagnosis. Come and see how you are shaking their head. Yes, that's our problem. Don't do our job, do your own job. If you do your job, no one will take it away. So let's advance ourselves so that when we are now teaching pharmacology or whatever it is, or radiological investigations, we'll be teaching it from the perspective of our profession so that the people we are teaching will now understand that field, but from the perspective of physiotherapy, not from the perspective of medicine. But we need to now advance ourselves in those areas so that we can be able to teach it properly. I just wish at some point we'll stop taking students there completely and leaving them. They will go there and learn how to do medicine and they will forget physiotherapy. If we are sending them because they have some information there beyond what we have learned, let it just be those concepts and principles they learn. But the actual application of drug use in physiotherapy, a physiotherapist should teach that. The actual application of radiology in physiotherapy, the physiotherapist should teach that. And we are empowered to do that, especially now that we have a DPT. These are courses that are in it. We'll learn. And we are going to begin to put that in our clinical pathway. I will also speak with the college, postgraduate physiotherapy college. Let them put these courses there so that people will learn them. By the time you be specialized and you can teach those, who are you going to go and call to come and take those courses for you and teach people medicine instead of physiotherapy? So I think we'll get there. At least we are discussing these issues. So we have started. The journey has started. Thank you.
Thank you, sir. Thank you, sir.
Yes. So I think because of the fact that we have already exceeded the time we agreed, we'll stop here. We'll take 1 hour, just like we did last time, meaning we are going to come back by 1:45. Thank you so much, everyone. May God bless you all.
Thank you, Prof.
Okay. Good afternoon, everyone. You are all welcome back. So we're going to continue from hematological diseases. So what are the red flags? So with this, it's the conditions that we are looking at. We are looking at the conditions that the patient may have that will now serve as red flag for hematological diseases. So in most, what we have seen has been either a combination of risk factors, symptoms, and signs that form a red flag. But because many conditions can predispose someone to having hematological issues, and remember, even in our clerking, we have past medical history. So it is from that past medical history that we can be able to see if this serves as a risk of having hematological diseases. So that's number one. We're looking at viral diseases. A patient that reports a viral disease or infectious hepatitis. So this is a problem of the liver, but can predispose to having hematological problems. Rheumatoid arthritis is a joint disease, but can predispose the patient to having blood problems. Liver cirrhosis, it's a liver problem. But when someone has that, can suspect hematological problems. Autoimmune diseases. So the immune system accidentally attacks the body So severe infections, any severe infection, bone marrow failure. So when a patient has gone through chemotherapy or radiation therapy, they begin to have bone marrow failure. So that also can lead to blood problems. And usually these conditions will mostly lead to reduced white blood cell count, which is called leukocytopenia. So low leukocyte count or low white blood cell count. All these conditions could lead to that. So another indication of low white blood cell count, instead of looking at the conditions, we are now looking at symptoms of the patient who present with, not the past medical history. And therefore, we could see fever, chills, sweats, just like we have seen in many other conditions that come with infection. So, but this is not really infection, but comes with those because there's reduced white blood cell count. Leukopenia is synonymous to leukocytopenia. So they are all problems of low white blood cell count or low leukocyte count. So sore throat is there and cough. So the patient has sore throat, cough, sweats, chills, and fever. Might look like a pulmonary problem, but can be a red flag for hematological disease. Then feeling weak or tired. Swollen lymph nodes. It's very important to know where the lymph nodes are. Whenever a patient is feeling weak or tired, palpate the lymph nodes and see if they are swollen. And therefore, it's also important to know the normal size, so that if the size or the feeling, the touch changes, we'll be able to know if this is something that is related to blood issues. When there is swelling or discomfort in the abdomen, so the patient will report discomfort or that the abdomen is swollen, pain in bones or joints. So the patient reports pain in joints. Some people will say, I feel the pain inside my bones. So those kind of patients, I've had many patients say, why do you think it's inside your bone? They say it's in the bone that they feel the pain. So these are symptoms that will make you to suspect leukemia. So when there is cancer of the blood. Then bruising in the skin. Remember we talked about bruising in the skin earlier. There's no accident, no scratch the skin with any object, but the skin is bruised, or the joint is bruised, or a mucous membrane, either in the mouth or some other places that have mucous tissue. There is bruising without any explanation. Then hematomas, when blood accumulates in a particular area as a result of vessels or capillaries having blood move out of the vessels and it accumulates. So either through palpation in the body or through ultrasounds or through any other investigations that show accumulation of blood in the body where it's not supposed to be. Then swelling. Petechiae, this is a skin problem where capillaries release blood and it accumulates under the skin and it shows in form of like spots that are either red or pink. So you see red or pink spots on the skin. I will try to show these pictures because you appreciate it more with the pictures. So maybe after the slides, I will go back and show pictures of some of these things. So decrease in number of platelets. So thrombocytopenia is about platelets. They guard the body, protect the body. When they are less than 150,000 per millimeter cube, you begin to have these symptoms: the bruising, the hematomas, the swelling, and the skin spots on the skin that are pink or red. This suspect thrombocytopenia. All these are red flags. When you see them, you refer either to a physician, or if you refer directly to a specialist, you refer to the hematologist. Okay, so let's go back and see if we can look at pictures. So let's see which ones need. All these conditions are conditions. Fever, we know fever, chills, shivering, sweats, sore throat, cough, all these are easy to identify. Feeling weak or tired. So let's see palpating lymph nodes. Okay, so I'm just going to share so that we'll just see a little of how to do that. Or this is something really that we need to have a training on separately at some point in time. So at the neck, lymph node palpation, you see the location and how you palpate. It's one thing to palpate, but it's another thing to know what you to feel, for you to know if they are swollen, the lymph nodes are swollen. So it's good to go back to the anatomy. You can see a number of these pictures showing the location where you have lymph nodes, but the clinical examination, you can see how to palpate them, either from the front or from the back. There are others around the armpit, also palpation from there. Yes, so these are just a few. I think it's important to learn how to know the location, how to palpate, and what to feel if you palpate. Very, very important. Usually when they are enlarged, you can even see it obviously without even the palpation. So it's important. At least we have seen both of the necks, the neck and the armpit. So let's see another thing. So swelling or discomfort in the abdomen, you can be able to do that taking the history or palpating or through scan or any other investigations. Pain in bones or joints, bruising in the skin. So let's see if we can get bruising in the skin. So this is it. So this is something that I would expect with an accident, or if someone bruises it by possibly moving to or against the wall. But all this are not bruises. You ask the patient, how did you get this? Is it through accident? He said, no, it just appears, just like that. So all this shows bruises, but it's not as a result of accident or any trauma. So when you see that, and you have the swollen lymph nodes, discomfort in the abdomen. No, sorry, that's another thing. Bruising in skin, joint. So let's see bruising in the mucus. Okay, so you can see the mucous membranes. So it's similar to what you see in the skin, but this one is in the mucous membranes, either in the mouth or in other areas that have the mucous membrane. Let's see hematomas. So this is similar to the bruising, but the difference will be in hematomas, you are going to see that when you touch it, you have a feeling that there is fluid under the skin. And the fact that it's red is what indicates that it's blood. So it's blood oozes out from the capillaries. And because the capillaries are the ones that are in the skin, you have the blood accumulate between the skin and the muscles or other soft tissue structures. And this is how it looks like. So when you see that, it's part of the things that help you to think of red flag for hematological diseases. So let's see picture card. Yes, so this one is not continuous like you see in the other two that we have seen, either the bruising or the hematoma. This one will have spots, but they are red or pink. So you see that there are spots, either red or pink, all through these are spots. Now, I would have asked for this in black, dark skin, because I know people may ask. Okay, so they are seen in black and dark skin, but they might not be as red as it would be in those that are light-skinned. Let's see, there are spots. But of course, when you look at integumentary system, differential diagnosis, there could be a number of other conditions that could mimic this. And it's all about clinical reasoning and the understanding of those diseases to be able to differentiate between this particular one and others. But then this is just an example of how it will look like. Yes, so I think next is going to be integumentary. Because they are similar, I will take them together. Then I will open the floor for comments and discussions. Yes, so usually what colors of the skin will you see to make you to suspect organic pathology? Here it even indicates in some what condition it is, but remember we are not after the condition, we're just after suspicion that there is an organic pathology in that system, not really a specific condition, because we are not going to treat specific conditions, we are referring. So when an individual look whiter than normal, so that's the pallor. I think I've shown the picture earlier. When someone will say it's pale, just come white, meaning there is reduced blood, anemia. So when there's anemia, the patient will look whitish, or when there is lead poisoning, or when there's internal bleeding. So they are all related to blood. Chronic GIT disease is not related to blood, but the patient can become pale. So when there is cancer, when there is parasitic disease, so a disease that comes through parasites. So all this could lead into the patient looking pale, whiter than the normal color. Then cyanosis, blue. When you see bluish coloration, it's also a red flag, just like pallor. So when there is a cerebrospinal disease, when there is high blood iron level called hemochromatosis, or vasomotor instability, there is vasodilation, the cutaneous structure, or sensation of heat, decrease in core body temperature. So all this could be suspected when there is bluish coloration in any part of the body. So bluish coloration. Then when the patient is yellow, jaundice, there is a liver disease or there's hepatitis. So when the patient is yellow, then arterial insufficiency ulcers. Arterial insufficiency ulcers. So this is peripheral. When there is peripheral vascular diseases, it's punched out appearance. It's painful on the skin, and it occurs distally. Usually see it distally. See still the issue of semantic qualifiers. You see it distally. So how do you know if there is arterial insufficiency ulcers? So it's because of the arterial insufficiency that the ulcers will appear, usually in the distal part of the lower limb. So that's what is called the ankle brachial index. You take the blood pressure in the upper limb and you take the blood pressure in the lower limb, then you divide that of the upper limb over that of the lower limb, and the result it gives you, if it is between 1.19 to 0.95, this is normal. But anything less than 0.95 is abnormal. It indicates arterial insufficiency. So just take the blood pressure, both in the upper limb and lower limb, divide, and then you see the result. So this also you can see is an evaluation. You take the blood pressure, it is an examination, but it doesn't give you an indication of whether there is arterial insufficiency in the lower limbs. So you now do the calculation, and the result will interpret the presence of a problem in the arteries. Then venous insufficiency, pitting edema. We know this is a very common thing that we have in patients, and we always touch to see if it is pitting. Fibrosis. So maybe we'll show this. So when you have accumulation of fluid somewhere in the fibrous tissues, and scarring and fibrous formation leads into hardness in the area, fibrosis. You touch the skin and it's warm. Then hemosiderin staining, when blood leaks from the capillaries. I think we have seen this earlier, but it wasn't called hemosiderin staining. It's about blood leaking from the capillaries, when we saw hematomas and other things down there. So these are just pictures. Skin ulcers, remember, we talked about the arterial insufficiency. And also on the right, you have the venous insufficiency, while on the left, you have the arterial insufficiency with the bruises. So when you do the brachial index, you are going to see that it's less than 0.95. So this is something that shows the venous insufficiency. Rash spreading quickly and accompanied by fever. So the patient has rashes, it spreads over the body very quickly, and then reports fever, fatigue and malaise, joint pain. So this indicates possibility of having skin cancer. Brittle hair leading to breakage, hypothyroidism. So the hair is brittle and it breaks. It's a red flag for integumentary. Might indicate hypothyroidism. Nail bed appears white for more than 2/3 of length. So the length of the nail bed usually is it's a small amount that's white. But in this patient, more than 2/3 of the nail bed is white instead of red. And the end remains pink. So it's only the end of the tip of the nail that is pink. This is an indication of cirrhosis of the liver or a heart disease. So always look at the nails of the patient to see that white that is less than 1/3 at the ends of the nail. Now it's moving towards the edge, outside the edge. Then clubbed nail, we'll see pictures. Clubbed nail. So it's not flat, it's clubbed. This might indicate heart and lung diseases. Then nail pitting. When you press it, you see it's pitting, and there are small punctuate depressions. This may indicate psoriasis. Then transverse white lines. You'll see the picture. You see on the nail, there are two white lines crossing the nail. This shows an acute illness, heavy metal poisoning, or arsenic poisoning, or when the patient is on chemo. So these are, remember the pitting one and the transverse white lines. You see the white line? So it's important to note these things because you can use it for evaluation to be able to suspect conditions that are organic in nature. Lindsay's nails, distal brown traversed band for kidney disease. Visit. Lindsay's nails. So let me ask if there are any comments now before we continue with oncological diseases. Are there any comments? Okay, can't see any hands. We'll proceed and look at oncological diseases. I think we have two systems. Oncological disease. In the past, I wasn't including pediatrics. Someone said we're in pediatrics. Can we see some of the things we do in pediatrics to indicate organic pathology? So I've added a few slides to do that. But let's now look at oncological diseases. What do we see to suspect cancer? Remember we talked about lymph nodes. So when there are lumps or nodules, sorry, not in the lymph nodes, this lymph node enlargement, but these lumps or nodules. So we are going to look at pictures of lumps or nodules when we see them, past medical history of cancer or neurological symptoms. So whenever a patient reports past medical history of cancer or they have neurological symptoms, lumps or nodules. So lymph node enlargement. So when there are lymph nodes, there's enlargement of the lymph nodes. Lymphadenopathy is suspected. Palpable, fixed, irregular mass in breast or axilla. So that is very important for women to be doing the self-assessments. So, but if the patient reports to you as a physiotherapist of having those palpable, fixed, irregular mass in the breast or in the axilla, or when there is an assessment and it yields that, it's a red flag. Idiopathic muscle weakness, no explanation, no cause identified for the muscle weakness. And you do the deep tendon reflexes and they are decreased. And you can't think of any disease or injury in the brain or spinal cord. These are early warning signs of cancer. Unexplained bleeding is a red flag. There's a bleeding, it can't be explained. It's a red flag. Refer. It could be a cancer. When there are signs of metastasis, past medical history of cancer. So whenever there's a past medical history of cancer, you just need to have one issue and it can form a red flag. Because people that have had past history are very much at risk of having it come back. When you have pelvic, groin, sacroiliac joint, back pain, and sciatica, and there is past medical history of prostate cancer, can you see past medical history appearing over and over? There's past medical history of prostate cancer, And we know the area of the prostate sends referred pain to these areas, especially the back. So when you see the pain and the past medical history, it's a red flag. Then yellow flags. Any patient older than 50, do further assessments to see if there is a red flag for oncological disease. See past medical history of cancer that I was talking about. Whenever a patient has a past medical history of cancer, observable to see if there are other symptoms that could lead to referral. Back, pelvic, groin, hip pain, or abdominal complaints, palpable mass. These are yellow flags. You need to assess more. Prolonged excessive menstrual bleeding. So in females, can't explain it, but it's prolonged and it's excessive bleeding. Recent unexplained weight loss of 10%. There is no reason. There's not changed pattern of eating. It's not, maybe not even doing exercises. No any disease that has been diagnosed. But 10% weight loss and it's unexplained. Or more of total body weight. 10% or more of the total body weight within 2 weeks. So within 2 weeks, you lose 10% of your total body weight. It's in 2 weeks to 1 month. That is serious. It's a yellow flag. When there is a growing mass, not explained also. Increase in hematoma. So blood has oozed out. It should heal. And it should stay like that or reduce. But you see that the hematoma is increasing and there is no explanation for that. Because someone may have an accident or he will hit the hand and then he will do it again. Instead of healing, it will bring more blood. If there is nothing like that, it's a yellow flag for oncological disease. There are signs of nerve root compression. Signs of nerve root compression. Usually, cancer will lead into those signs. It's a yellow flag. Ask for other things to see if it is cancer and not just neurological or musculoskeletal conditions. So finally, I'll just quickly go through this. These are the pediatric conditions for neuromuscular aspect. So that is why I'm doing this now, because later I realized those musculoskeletal or neuromuscular in adults may not apply to pediatrics. So abnormalities of head, these are red flags, microcephaly, micro or macro. That is why it's important to measure the circumference of the head. There is a book. I will share the book and maybe give you the pages for where you do these assessments and how you do them and how you interpret them for pediatric cases. I will post the book on the group. So fontanelles, the book also gives explanations on the processes of assessing the fontanelles. Then the location of the face. There are some children that you see the location of the face is abnormal, or their eyes, location of their eyes is supposed to be in the normal location, but either they are too close to each other, they are far from each other. One is above, one is below. There's something with the location of the ears, the positioning towards the front, towards the back, and things like that. Midline defects of neck and spine. So midline defects, either it moves towards one side or the kyphosis, lordosis, those kind of things. Integumentary signs of underlying deformity. Abnormal muscle tone. So look at the muscle tone, whether there are tremors, there are fasciculations, lack of coordination, unusual movements. In an adult may serve as a yellow flag. In a child, it might be just directly a red flag. And these things usually, or anyway, it says neuromuscular ones, and therefore you know the referral is either to be to a physician or to the neurologist or orthopedic So sorry, it's a pediatrics. So to the pediatric doctor. So they have headaches, or they have seizures, they have bulbar signs, or dysfunction of autonomic nerves, abnormal gaits, might be ataxia, tremors, and what have you, fine motor difficulties, unusual mental status, abnormal eye function, arrested, deteriorating, or abnormal motor development, sensory changes, numbness, paresthesia, whatever, dizziness, fainting, onset of falling, inability to stand, hypo or hyperextension, abnormal sweating, irregular respirations, cerebrospinal fluid leak from ears to nose, signs of increased intracranial pressure. So in them, the fontanelle, you'll see the bulging. They will have headache, lethargy, vomiting, irritability, distended scalp veins. These are things that you can be able to see. So that's for neuromuscular. For cardiopulmonary, in pediatric, they don't feed well, see red flags, poor weight gain, they are not gaining weight. The mammals, you see blue coloration, rhinorrhea, fever, abnormal heart rate. So go through them: fainting, anorexia, weight loss, cough, cyanosis. You see these things in children, the red flag, it might be a yellow flag in an adult, but in a child, even a yellow flag that's in an adult could be a red flag in a child. So this is the end of the slides. If there are comments, let's take them. If there are no comments, we'll go to and look at few of the case studies so that we'll reduce some of the case studies before Wednesday. That will give us the opportunity to take more. Yes, Mr. Anozie, go ahead, please.
Yeah, thank you very much, Prof, for the lectures, and it's really been nice. And I've seen that we have a lot to embrace. We have to be open-minded to learn these things and to improve more. I also want to encourage each and every one of us to open up our minds to and speak to to latch into what is happening now. I've seen that in the areas where we would deal like red flags and all that. I also want to emphasize, because I've noticed that in some clinic areas, especially the outpatients, even the little things like vital signs are not done routinely in some, especially musculoskeletal clinics. But we have seen that even while you are taking your vital signs, you may even be able to start finding out some things that can be like yellow flags, or you may even start to discover something. So I would encourage each of our clinics to ensure that everything is there, even things like having an ear probe, like a thermometer, to be able to check, because it's not enough to just touch the patient and feel that they are warm to touch and all that. Should be able to have things like that, to be an ear probe to check their temperature, or something that will show us, what the temperature is all about. Because I know that most people will check the blood pressure, the pulse rate, maybe oxygen saturations and all that, but things like temperature is not being done. So we can start doing that. Then again, I'm also thinking now, because we're in the era of specialty. So these conditions, now we're talking about different systems and systems review. If you are in a specialty area, how will this apply in a specialty area? Like, for instance, if you are in neuro, definitely I wouldn't be. Would you need to do a system review generally that may even point you to do system review for other conditions, or would you just be focused on doing neurological review? Or would you have to do all the systems, even irrespective of your specialty? So I just want you to just give us is it like is there going to be an SOP for this systems review format of clerk? And I just want to really understand how it's going to be. Thank you, sir.
Yes, sorry, I was saying we have lost another that was lost. So
Did you get my statement? Sorry.
yes, I get most of your statement. It was just towards the end that my network flipped and I had to go off. But I agree with you strongly because I believe you have. Okay, yes, go ahead.
Yeah, the last thing I said was around the area of specializations. We are now in the era of specialization in physiotherapy. For instance, if I'm in a neurophysiotherapist and I'm supposed to be trained specially to have a thorough neurological assessment and carry out the neurological interventions for my patient. So if a patient come now with what you have exposed us to, it means that we're also supposed to be knowledgeable about reviewing all the system, not necessarily the neurological system, for instance. So I'm now asking, is there going to be a sort of like an SOP specific to different specialties, or will it still be like regardless of the specialty I find myself in, if I come across a patient, I will do the system review for this patient all through. Then there maybe now do more extra because I'm more into a neuro perspective and do an extra work on the neuro part. So I just want to see how do we want to harmonize these things now with regards to the specialty.
Okay, thank you very much. This is a very good one, very important question. There is a difference between systems review and review of systems. I've explained this before. With systems review, you are reviewing each of the systems to see if there is a red flag that will require referral. System review, everyone, notwithstanding your area of specialty, you will do systems review. What does it mean? I'm in a neurological physiotherapy. When a patient comes to me, especially first contact, I'm going to assess the patient and do systems review for musculoskeletal, even though I'm not a musculoskeletal physiotherapist. I will look at the cardiovascular, I will look at the pulmonary system, I will look at the integumentary system, with the aim of seeing if there is any red flag for organic pathology that requires referral to a physician. I will do that. A musculoskeletal physiotherapist, orthopedic physiotherapist, will also be watching out for the presence of any neurological red flags or urological red flags or GIT red flags. They will do that. But with review of systems, this is where you must have suspected a problem in a system. And you want to go further to see what the problem is. So when you have your suspicions, you have this systems review, you have your yellow flags. You now want to isolate that system to further find out if there is a red flag. Or you see some yellow flags, but that yellow flag is not for organic pathology, it is for movement-related problems. And you now want to continue on that system to do your history, your assessment until you reach a diagnosis. That is a review of system. So you might not go deep if it is within your scope of practice to get to a diagnosis in a musculoskeletal area if you are in neuro. The moment you suspect that the problem is not neurological, if it is organic pathology, of course, it's a referral to physician. But within, in-house, I get to a point that I suspect musculoskeletal problem from movement impairment perspective, I will not continue with that system until I get to a diagnosis. I will refer to the musculoskeletal person. But that initial stage that I need to suspect the presence of a problem that is not within the scope of my practice, either generally looking at organic pathology or internally within the profession looking at another person's specialty, I'm going to do the assessment. I'm going to do the analysis or the evaluation. But then I will know my limit, whether I can go through with that system until diagnosis or I'm going to refer. So this is the situation. Everyone is expected to do systems review. Well, in fact, it is an undergraduate course. We did it in DPT. Even though we were graduates, I had my master's when I did DPT. But the program I did was an upgrade of my bachelor's degree. Right now, we have universities that are offering DPT. I know in Chrisland, I was the one that taught them systems review. And this is just a few weeks back. I was in Chrisland. For the whole day, I took them systems review. And they are undergraduate students, and I taught them all these things that I've done today. We did all this within a few days. And I also continued online at some point to give them further information. And then someone that was on ground continued from where I stopped. So this for everyone, not just a particular specialty. Okay, any other comment? And for the first part of your comment, I appreciate that we have a lot to cover. We have a lot to cover. The problem we have right now is that we are looking backwards and forwards. Forward, because we have a lot of gap in our undergraduate curriculum. We practice now, but there is a lot that we did not cover in our undergraduate curriculum. So we need to cover that. Then we need to begin to look forward towards specialization. So we have a lot and we need to cover up. So I'm going to share a case example on gallbladder pain. And I will appreciate if someone can help read it. Yes, please, can someone help read what is on the slide? This is on gallbladder pain from Goodman and Snyder.
I want to read now, yeah?
Okay, yes, please go ahead.
Yeah. A 48-year-old school teacher was admitted to the hospital following an episode of intense, sharp pain that started in the epigastric region and radiated around the thorax to the interscapular area. Her gallbladder had been removed 2 years ago, but she remarked that her current symptoms were exactly like a gallbladder attack. The client was referred to physical therapy for back care / education on the day of discharge. On examination, the client was in acute distress, unable to tolerate a full examination. She had not been able to transfer or ambulate independently. She was instructed in relaxation and breathing techniques to reduce her extreme level of anxiety associated with pain and giving supportive reassurance. Instruction and assistance were provided in all transfer to minimize pain and maximize independent function. Even at discharge status, outpatient physical therapy was recommended for follow-up intervention. She returned to physical therapies as planned and was provided with a back care program. She was also treated locally for scar tissues adhesion at the site of the gallbladder removal. Symptomatic relief was obtained in the first 2 sections without recurrence of symptoms. This case example is included to demonstrate how scar tissues associated with organ removal can reproduce visceral symptoms that are actually of musculoskeletal origin. The opposite concept of what is presented in this test, this may be more of an example of cellular memories, sustaining a somatic reflex via the actions of neuropeptides at cellular level. In brackets, see discussions of psychoneuroimmunology in chapter 3. That's all.
Yeah. Okay. So thank you very much. So this does not have questions, but we are going to have another one that will have questions just like we did on Wednesday. So I don't know if there is any comments on this. Myself, I've not really read it earlier before coming here, but I think it's straightforward, showing these issues of diversities and relationships between musculoskeletal and the viscera. That one can refer pain to another, a problem in one could reflect in another. Yes. Any comment on this before we go to another one? Yes, Dr. Ajiboye.
Thank you, sir, for the opportunity to speak to this scenario. I was so excited when we were going through it, because in 1999, I had cholecystectomy done as a result of gallbladder stone. And the scenario painted here was exactly what I passed through. It took over 10 years before I could recover from that kind of pain as a result of scar tissue on the operation site. In fact, it made me to doubt that maybe they didn't even remove it, they just opened me up.
Exactly.
They just opened me up and closed it back. But I remember we took the sample of what they removed, we took it even for histological reports.
Yes.
So it's just the way it is. And that's the reason why we should go beyond just treating symptoms, so to say. This one has painted the real example of what happens. Because of the scar tissue additions, I suffer from this for over 10 years. That's why that I was a physiotherapist and I'm a physiotherapist. So I just want to learn my experience in this. Thank you.
Thank you very much. So that's a very good one. At least we know we can be able to explain the pain that the patient is having, rather than thinking of treating it from just the perspective of pain, but trying to look at it from the perspective of the cause of the pain. Wonderful. Thank you, Ma, for that. That is even a better experience than the one that you see on other patients, because you are feeling it in yourself and you are seeing it in yourself, and therefore you can explain it more than just seeing it in patients or hearing what they have to say about the symptoms. Thank you so much.
Yes.
So I'm going to share another case study. Okay, so I've got another one. This is for urological disease. This one has a question. And therefore, after reading, we'll discuss the question before we see the question. This screening in the presence of risk factors for kidney disease, still from Goodman and Snyder. Can someone help read? Another person, please. Should I start calling people?
Okay, Prof, let me read.
Okay, thank you.
Good afternoon, everyone.
Good afternoon.
A 66-year-old African-American woman with a personal history of systemic lupus erythematosus, SLE, lost her balance and fell off the deck at her home. She sustained vertebral and rib fractures at T10 and T11. She is a retired paint factory worker. She reported daily exposure to paints and paint solvents during her 15 years of employment. She was seen as a walk-in at the local medical clinic where she is a regular patient. She did not see the rheumatologist who was managing her SLE. The attending physician told her the injuries were probably from the long-term use of prednisolone for her lupus. She was referred to physical therapy by the attending physician for postural exercises. During the interview, when she asked, "Are you having any symptoms of any kind anywhere else in your body?" the client admitted to a pink color to her urine and some burning on urination. These symptoms have been present since the day after the fall 3 weeks ago. There were no other signs or symptoms reported. Blood pressure measured was 175/95 on 3 separate occasions. The client reported her blood pressure was elevated at the time of her visit to the doctor, but she thought it was caused by the stress of the fall. Question: as you step back and conduct a review of systems, what are the red flags to suggest medical referral is needed? To whom do you refer this client?
Good. Thank you very much. Now, can we answer this question before we look at the answer? Anyone wants to attempt? Yes, Mr. Anozie.
Yeah, thank you very much. This question is very elaborate, and I've seen.
Sorry, excuse me. Please, can you scroll it up again? Sorry.
Oh, okay. No problem. No problem. Okay, yes, from here, right? Okay.
Yeah, from the question, we
can't be able to see the whole thing. Okay, let me reduce this. Aha, I think I should be able to show the whole thing if I reduce. I think the whole thing is appearing now. The only thing is that the question is not there. So go ahead, yes.
Better.
Yeah, this patient is elderly patient, 66-year-old, history of systemic lupus erythematosus, which is an autoimmune disease, and sustained fractures, and is a retired paint factory worker. So what I'm seeing here is that she already has a background condition, which is the systemic lupus erythematosus, which necessitated her using prednisolone, which is a corticosteroid, and prolonged use of steroids can lead to risk of osteoporosis. And she fell off. She already had fracture at T10, T11. Now, she's seen by the rheumatologist. She's seen by the rheumatologist. Can you hear me?
Yes, we can hear you. Go ahead.
Yeah. So she's seen by the rheumatologist and also has been seen by the physiotherapist. So the red flags that I'm seeing here is I'm going to give the things I'm considering. The age, 66-year-old. Then the fact that she's been on prolonged use of this steroid, which is risk of osteoporosis. I will be considering that. Then I'll also be considering the color of the urine, I'm identifying that of a pink color of urine and some burning sensation on urine. So on the urological review, we could find out that that's the color and burning sensation there is also already a red flag. And the symptoms has been present since after the fall for the 3 weeks. So I'm going to probe for that for the fall after she had that. Could it be that there are other things that has happened? Then also from the blood pressure, we see that the pulse pressure is really wide. That's like 90 plus like 80, which is a wide pulse pressure is also something I should take note of. And I think I just want to point out the things that sustained my interest then before we start talking about who are we referring to. So on a nutshell, I would say the burning sensation of the urine, the color of the urine too, is what I will look at. It's a red flag for me.
Red flag, yeah, okay.
Yes, then I'll stop here for now so that the other people can contribute.
Yeah, sure. Thank you very much. So I want the next person that will speak to consider other questions there. So he has brought out some of the things that he feels are red flags to suggest medical referral, but another question says, to whom do you refer this client? Now, if I don't get hands, I'm going to start calling people. On my list, I remember last time we met, I called Sophia, she spoke. Abdullah Abubakar spoke. Ademola Lajide spoke. Adenekon Kayode. Even if the person did not speak, I think the person sent a message. So I'm going to go to the next if I don't see a hand. Okay, Dr. Ajiboye has saved you. If not, I would have gone one by one calling people. Yes, ma.
Yes, thank you so much, sir. Apart from what the first speaker has pointed out, I think the nature of our work also, being a retired paint factory worker, should be of concern to us. That maybe occupational hazard must have resulted even into the XLE that he presented with. But whom are we going to refer to? I could see cardiologists flagging out here, and I could see urologists also flagging out because of the very high blood pressure. We should seek the attention of the cardiologist. And because of that pinkish color of the urine also, one should consider referring the patient to urologist. Thank you.
Thank you very much, Ma. I'm very happy that the two contributors did not just focus on the urological system, because the heading there was about kidney. And therefore, there is that tendency to be biased and only think of that system. But I'm very happy that you also looked beyond that particular system and suggested problems in another system. That's wonderful. The answer may not report system problem in any other system apart from the kidney, but the fact that they ruled in that kidney problem was what made them to pick this as a case study under the urological system. So it's very possible someone presenting with this, another patient presenting with something similar, at the end of the day, they may rule in a cardiovascular problem instead of a kidney problem. And that is why it's important to look wider beyond what is more obvious in the patient's reports or symptoms and signs. So can we have someone help read the answer?
Red flags.
Okay.
Age over 40. Age over 60 is a risk factor for kidney disease. African American descent at risk for diabetes, kidney disease. Long-term use of non-steroidal anti-inflammatory drugs, synergistic nephrotoxin in combination with certain chemicals such as paint and paint solvents. Elevated blood pressure, change in color and pattern of urination.
Okay, before you proceed, Sorry, before you
Yes.
proceed, can we pick out the ones that were not mentioned by the previous speakers?
That's African. Okay.
African American descent.
Africa,
Exactly,
yes.
because I observed
African
that it was
age
there
over
very
40.
clearly, but we
Yes.
did not link it to kidney problem. So can you
Yes.
say it's a risk factor, and it is part of what contribute towards a red flag? What other things did we miss out?
Age.
Age. Okay, we didn't. None of you mentioned age, right?
No, I mentioned
And
the
I
age.
had
I
it
think Mr. Anozie mentioned age.
I had it.
Yes. So I had someone also mention the long-term use of NSAIDs. Was it NSAIDs that you
It wasn't NSAID I mentioned. I mentioned long-term use of steroid. Yeah.
Steroid, okay.
But this is, yeah.
So this is another thing that we have missed from there. Then elevated blood pressure, you mentioned it, but I think you related it to cardiovascular, not urological. What they are saying is that it is also relevant in urological. Then the issue of certain chemicals, the issue of chemicals. We also related the use of chemicals, and I think Dr. Ajubo mentioned that, but possibly towards the SLR, not the kidney problem. So what we are doing right now is what is called metacognition. If you remember metacognition in that we did in clinical reasoning, we said, we read this thing, but how many were we able to bring out? When we now look at it, if we are going back now to read it again, we'll read maybe all these ones that are here, including the African American and the issue of the NSAIDs. So that's why I said let's stop and look at what we missed. That is a form of metacognition. Yes, please, can you continue?
Okay. The therapist may not recognize specific factors present that put the client at increased risk for kidney disease, but the obvious changes in urine color and pattern, along with changes in blood pressure, require medical referral. Without the medical records, it is impossible to know what, if any, testing was done related to kidney function, e.g., urinalysis, blood tests at the time of the initial injury. A phone call to the referring physician is probably the best place to start. Documentation of the recent events and current red flag symptoms should be sent to the referring physician, the primary care physician, and the rheumatologist, if different from the primary care doctor. Physical therapy intervention is still appropriate given her musculoskeletal injuries. Further medical assessment is warranted based on the development of symptoms unknown to the referring physician.
Good. Very, very good. So now, see the issue of asking for lab tests. And you see what this is saying is that instead of just asking for lab tests, you can now call the physician or write to find out if there is any test that has been done before the referral that they did not send the records. So that instead of asking the patient to do it twice, you can get those results and you look at them. So that's a very good one. Another thing is the fact that this is a keep and refer decision. Because there is a case for the physiotherapist to see, and there is a case that needs to be seen by a physician. I can't even remember what case it is that the therapist need to keep for, but I can see the last statement indicating that. Can anyone remember? I don't know. Exactly. See, I missed even that one because my level of attention is low. I missed that one, but that's a good one. This shows that it is a keep and refer case. Because if it was only the organic pathology that is leading into the pain, that's the important thing. Let's assume it's a kidney problem referring pain to the back. Will you keep the patient and be treating the back?
No.
You will not. You will only refer so that when they treat the organic pathology in the kidney, that will also take care of the back pain because it's not a musculoskeletal thing. But because of the fact that there was... Exactly. If there's a fracture, it has been reduced, and therefore there is definitely a physiotherapy case. But then there is an underlying disease in the kidney. And therefore, you are referring for the organic pathology in the kidney, and you are keeping for the musculoskeletal problem that requires physiotherapy. So that's another good one that shows keep and refer. So thank you. Let's see. We'll just take one each from each of the systems that we considered, and then we'll close. So this is from urological. Let me see. Okay, maybe if we can have genital, anything from the genital perspective, not the urological. This one is a very short one. It is on prostate cancer. So let me share it. Yes, can someone help us read prostate cancer?
A 66-year-old man with low back pain was evaluated by a female physical therapist, but treated by a male physical therapy aide. By the end of the third session, the client reported some improvement in his painful symptoms. During the second week, there was no improvement and even a possible slight setback. During the treatment session, he commented to the aide that he is impotent. Question: what is your key referral decision? And explain your rationale.
Now, before we answer this question, let me ask you another question. What do you think of that first statement? What do you think of that first statement?
The patient was not confident in opening up to the female therapist at first. Okay. But when he saw the male therapist, he was confident enough to share the problem with the physiotherapy aide.
Okay, wonderful. That's a good one. It's something that comes from the whole brief history, But I don't think we can pick that from that first statement, from where it says a 66-year-old man to where it says physical therapy aide. I think it's when you read the whole setup that you will see that. But I'm very happy that you raised that. Very happy you raised that because it's something also that's coming out from the whole case scenario. But what I'm after, maybe let me, evaluated by a female physical therapist, but treated by a physical therapy aide. It's not even the female and the male that I'm after.
Yes,
evaluated by physical therapist, but treated by a physical therapy aide. That's where I'm after. Look, this is in the US. We're here in Nigeria. What do you want to say about this to help us assess or evaluate our mindset?
Yeah, can I speak, sir?
Yes, please go ahead.
Yeah, physical therapy aides are meant to take orders from the physiotherapists. So the physiotherapist examining and planning treatment could give out some instructions to the physical therapy assistant who has been trained to be able to deliver some intervention. However, is not able to modify any treatment plan that the physiotherapist has given because the physical therapy aide is not qualified to do so. So I guess from what I'm seeing here that the female physical therapist had planned the treatment and and handed it over to the physical therapy assistant to carry on. So I think we're supposed to work hand in hand with them really. But the only problem is that I have about it was that by the end of the third session, during the second week, then there's a problem. There was a setback. Could it be that the therapy aide was not following the right procedure, or I don't understand. I don't want to go further than this here. Yeah.
I think we'll get that answer from the answer page. It's not that they didn't follow. It's because of something that, okay, anyway, let me not go into that, but we'll see the answer. I'm sure it's not because he did not follow the instructions. We'll see the answer so that I will not preempt what others are going to say. But I agree with what you said. We need to work hand in hand. So meaning it's a normal practice for a physiotherapist to plan the treatment and a physiotherapy technician or assistant to now give the treatment so that the physiotherapist can go and evaluate another patient or plan treatment for another patient. That way you can cover as many as possible. So this is a common practice. Another thing, they said the female physical therapist evaluated. And what we are doing is evaluation, is clinical reasoning. And that is what differentiates a professional and the assistant. The professional thinks and evaluates and comes up with what the problem is, even before planning treatment. Because planning treatment is not a big deal, but evaluation, knowing what exactly is the problem, is the first main issue. But the assistant, when they are told this is the intervention to give, maybe they even know how to apply the intervention more than the professional themselves, unless if it is in an area of a specialization that only a specialist can apply that particular treatment. So this is another thing. But our fears, I always say, are genuine. If hospitals will take the aides or assistants and not take the professionals, we have a genuine fear. And therefore, people that are saying we shouldn't train assistants or aides, they have a case. But as I always say, rather than be consumed by our fears, let us come up with strategies to strengthen regulatory mechanisms so that we can still have the assistants, but at the same time, we control the fear by making sure they are not employed as alternative to the professionals. So thank you. This is an area that really matters to me a lot, especially because of the needs in the society and the fact that we have those fears stopping us from providing solutions to the needs of the society. Thank you. Dr. Ajiboye, you raised your hand. If you're still interested in speaking, go ahead, ma.
Thank you so much. You have really struck one of the aspects that I wanted to speak to. But the other aspect that I want to speak to is the aspect of reevaluating our patients, even if the physiotherapist assistants are available to be able to help us out. We should not just say because it's once off. Once we have planned the treatment, we continue like that. There should be regular reevaluation of the case. Maybe if after that assistant has administered the treatment for maybe 2 weeks, or before the 3rd week that the case started relapsing, if the physiotherapist has taken it up to reevaluate, maybe the need to modify the line of treatment or to even notice what has not come up initially will be there. So evaluation, reevaluation, replan, and we go a long way in helping to strengthen our intervention. Thank you.
Thank you very much, ma. That's a very good one. Farida Ibrahim, I saw your hand and you put it down. You must speak.
Good afternoon, sir. Thank you so much for the lectures. I wanted to speak about the patient from the beginning. I think from the age, there wasn't proper assessment, I would say, right from the beginning, because if there was proper assessment, we would have been able to rule out this problem, I think. So that's what I wanted to say.
Okay. Thank you. That's a good one too. If you look at the last statement, it says during the treatment session, he commented to the age that he is impotent. And what that means is that that information was not picked up by the physical therapist that did the evaluation. And remember, in the last case study that we looked at, there was a question there that says, do you have any other health problem apart from the one that we have discussed or you have presented? I can't remember the way they put it, but that's to say, is there any other thing? So if those kind of questions were put forward, or maybe even if that question was not put forward and they were asking, because it's low back pain, we know the genital system can refer pain to the low back. Do you have any problem with your ejaculation, with your erection, with this, with that? He would have mentioned something that will show that being important is there, and then they would have picked it earlier. And if they see that and it's a red flag, they would have referred to the urogenital specialist. Yes, Eugene.
Thank you, Prof, for the presentation.
Thank you.
Prof, I'm thinking that the physiotherapist that did the assessment is that either that he did not do a thorough system review to pick something that could hinder the progress of the therapy and improvement, or that as a physiotherapist, after assessment, he kept to himself what he found or referred to a physician through phone or through any means, but did not inform the aide about what he has seen and what he has referred to the physician. And the aide just continued treating the patient. After a while, the improvement ceased and started deteriorating as the case may be. That's my thinking, Prof.
Okay.
Thank you.
Wonderful. Thank you very much to all that have contributed. Can we have someone help read the answer?
Given the man's age, inconsistent response to therapy, and report of impotency, a medical referral was necessary. A brief note was sent to the physician relating this information and requesting medical follow-up. The therapist was careful to use the word follow-up rather than medical reevaluation, since the impotency was present at the time of the initial medical evaluation. The result: a medical diagnosis of testicular cancer was established. An appropriate treatment was initiated. Physical therapy was discontinued until medical treatment was completed and systemic origin of the back pain could be ruled out.
Good. So I think Mr. Nozia asked a question, and I said the answer will be here. And this is the reason. That back pain they were treating may not be a musculoskeletal problem. It could have been a referred, because I don't think there was any issue of accident or any symptoms that showed that it was a movement-related issue or an accident that should be a tear that goes to an orthopedic surgeon or things like that. And therefore, it is a case possibly of referred pain. They treated, maybe there were secondary reasons why the back will have more pain. That was sorted, but the source of the problem was not considered, and that is why there's a referral. And can you see what we said about last case, that it was a good example of keep and refer? What will you say about this particular example?
Can I say something, sir?
Sorry?
Can I just chip in something?
Yes, go ahead, please. But
yes,
answer that question. What case is this compared to the other one that was keep and refer? What will we say about this, about the decision? Because that is what they said. What is your keep referral decision? But go ahead, you can make your comment.
For me, for this patient, because the patient is elderly and complained of low back pain, and there was no trauma and all that. In as much as we know that for a male patient who is at that age, may likely have a prostate issue, of course, which was already established, which can refer pain to the back. I'm also going to be thinking about lumbar spondylosis, which is also consistent with that age group, which could also cause low back pain. So, and if you have lumbar spondylosis and with the pain that has been there for a long time, there could be some musculoskeletal implications that would have happened there. In as much as we are supposed to refer and everything, in the keep case, I would still, the fact that we referred is also good, but the fact that the patient was also given some physical therapy program before they eventually discovered the patient had the testicular cancer. I think that's the dilemma we face in the clinic sometimes. So at that point, you have to wait for the patient to come back with all the results, maybe screenings before you continue, especially when you have seen gotten some information like that. So I'm just thinking people who can also contribute.
Okay. Okay, you're still there. Okay, your network. Okay, I agree with you because of the fact that the history there is really very scanty, and therefore we can't just say it is only a referral case. And therefore, I strongly agree with you that we need to consider some other yellow flags for other systems, review them, It's only when we don't see any red flag that we say, well, or when we don't see any case that indicates there is a problem within the scope of our practice, then it now becomes a referral case, not a keep and refer. But I agree with you, if after thorough assessment, we see a musculoskeletal problem that is like the spondylosis that you talked about, we can keep. Even though I know it's not the spondylosis that will make us to keep, it is the physical diagnosis that we establish that will make us to keep, then it will be a keep and refer. But if not, if we don't see anything with the prostate problem that has been reported, it will just be a case of referral. But then, remember they also said it was known, and therefore it is not a new referral. It was known. That is just that the patient did not mention. So another thing is that the patient said, I'm important. Did the patient consult a urogenital specialist or not? If not, then it's a case of referral. But if it is yes, then are they currently seeing the specialist? If yes, then that also is not a case of referral. But if they say, I had seen them before, but now I'm not seeing them, and the back pain was not there before, now it's there, then it's a case of referral. So these are just some of the thoughts about decisions. Yes, Mubarak, Amin, right? I saw your hand. I hope I didn't preempt you. Maybe I said what you wanted to say, but still, please, if you are still there, let's hear from you. Maybe not. Okay, Mubarak is there. Go ahead.
Can you hear me, sir?
Yes, we can hear you. Go ahead.
Okay, thank you, sir, for the presentation. What I would like to say was about the decision of keep and repair, comparing to the other case. Like in this case, since it was said what the medical diagnosis has been established to be testicular cancer, and physiotherapy was discontinued. So I thought it was a referred patient, but then after the explanation, I got to see other things that could call for further review to see the possibility of keeping the patient. Thank you, sir.
Exactly. Thank you. That's also a good thought. So let's share another one. Instead of picking more from the census system, as I've said, I'll just pick one. Yes,
I'm sorry. Yes,
no,
I'm sorry.
No problem. Go ahead, ma'am.
Yes, sir. I just want us to have insight to this patient condition as well. It should be the responsibility of us as therapists to look outside the box. Even when we know that 66-year-old man is you can have degenerative changes. The same mind also should be in us that apart from that lumbar spondylosis, there are other possible conditions that this patient may be suffering from. Even in the choice of our modality, we should tread a good pathway that we don't use something that we inadvertently affect the one that has not even flagged up on that patient. Like this patient, if I have to manage, one will be careful in using electrotherapy like hot thing, because you know a 66-year-old person can still be having some underlying pathologies. Tests or other physiotherapy intervention may be considered instead of saying, okay, I want to treat as if no other issue can be considered. So the matter of thorough system review, we cannot compromise it, and we should just try our best possible to make sure that initially we do the right thing, and then we think outside the box to know the possible things that may crop up, and that any intervention we are giving to our patients will not be detrimental eventually. Thank you.
Okay. Thank you very much, Ma. These are really very good perspectives, and you can see as a professional, the challenge ahead of us. There are so many things to consider, so many things to sift through. At the end, you are after one thing. What is the problem and how can I treat it? But what you have to sift through before you get to that is plenty. But then that's what it means to be a professional. But I believe it's something that we can do. All we need to do is just continue to make the efforts, to continue to learn, to continue to apply. At some point in time, we will look back and we'll be surprised what we have achieved. Thank you so much, Ma. I have another case from the endocrine. I didn't want to show what system it is, so that at least it will give us more challenge to be able to identify from what system it is, but from the review itself, I think the name of the condition is there, and therefore I will not hide what case example is on. So we have Cushing syndrome from Goodman and Snyder. Can someone help us read the history and the question?
A 53-year-old woman.
I hope it's not
with Cushing
easy.
syndrome.
Jennifer, thank you so much, Jennifer, for always helping out. But next time I'm going to call the name of someone.
Oh, sorry. Okay, you can call
No,
the
it's
name,
okay.
sir.
No, thank you. Thank you. Go ahead, please. Go ahead. Go ahead since you
Okay.
have started. But thank you for contributing all the time.
You're welcome, sir. A 53-year-old woman with Cushing syndrome resulting from long-term use of cortisol for systemic lupus erythematosus reports the following problems: hair and nail thinning and breaking easily, temperature intolerance, always cold, muscle cramps, generalized weakness and fatigue. Her primary complaint and reason for referral to physical therapy is for sacroiliac joint pain as a result of stepping down off an unseen curb. You realize the signs and symptoms are of an endocrine origin, but you do not know whether they are part of the Cushing syndrome or a separate endocrine problem. Should you send this client to a physician or back to the referring physician?
Okay, thank you. Are they sure this is not a mistake? Maybe I was thinking say this to a client, to an endocrinologist, or back to the referring physician. Yes, I think there might be an error there, but let's discuss it. Notwithstanding what the situation is, let's discuss the case. Any comments? Don't want to see the hands that have been common. I want other people that have not tried. Let me begin to call names. Ajanaku Gabriel, you are next on my list after those that I called on Saturday or Wednesday. Ajanaku Gabriel. Okay, so it seems this participant is not with us. Dr. Jibril, take note. We don't hear from Aha at all. Oh, okay, it's you that's speaking. Ajanaku Gabriel, you don't get certificate if you don't speak.
Okay, it's Jibril.
Okay. Amara Precious.
I'm around. It seems I had my name.
Okay, yes, go. Oh. Fatima,
Fatima,
okay, Fatima, if you want to speak, go ahead.
No, sir. I just had my name. That's why I said, let me say that I'm around.
No, speak. Answer this question. Since you brought yourself, let's focus on you. You have everything, the brief history and the question are all there. Any comment?
Okay. Not really, sir.
Okay.
I was eating actually.
So no certificate for you. Dr. Jibril, take note. No certificate for Fatima. Amara Precious. Okay, no certificate for Amara Precious. I think Chidi Vincent made comments today. I think I've seen your comments. Chinwe Obikoye made comments today. Chuks Iwuchukwu, I don't think I heard your voice. Chuks Iwuchukwu. Someone must speak today. If
Yes,
not,
sir.
we will not finish. Okay, go ahead.
Okay. First of all, the woman is 53-year-old, and it's a woman. Has a systemic lupus erythematosus. So that's a sign that the red flag.
Okay.
So,
we can't hear him.
I can hear a little bit. I think he mentioned the condition and said because of that it's a red flag.
53-year-old and a woman with all these conditions listed. So the red flag is indicated.
Okay, that's fine. Can we have Janoku? We didn't say you should listen. We said you should speak. So unless you speak, there will be no certificate.
Okay. Can you hear me?
Yes, we can hear you.
Okay. I'm listening, but I usually don't, or let me say, I don't really like contributing, but I like to listen. I apologize on.
Okay, no problem.
Okay. Looking at the case, middle age, 53 years old, and being on medication, long-term medication. So I will consider looking at the hair loss and the thinning. And also, body temperature, always feeling cold. So that I will look at referring, and also, but I'll also consider managing because of the muscle cramp she feels, and also generalized muscle weakness or fatigue. So I'll consider those things in terms of managing also.
Okay. Okay. Thank you. You have saved yourself from not getting a certificate. But for Amara Precious, I can't speak now means you are not fully with us. You are doing something. So we'll give you a certificate because we have confirmed you are hearing or listening. But you must write a test. So Dr. Jibril, I'm very serious about this. Send some questions to Precious and let Precious answer them and before certificate is given. Because really this thing, if we are not together, discussing together, we are not going to get the substance of the evaluation we are talking about. Evaluation is the most important part. You see that case report, the last one we saw. It is very clear. They didn't say the physical therapist planned the treatment. They said the physical therapist evaluated, because evaluation is the main difference. Because planning, everyone can be seeing you planning and will do planning. But evaluation is something that you don't just see and copy, because it happens in the brain. It is about thinking, and it is about looking at diverse conditions and making different decisions and getting different problems. And so it's something that it's not everyone can do. And if we want to continue to see ourselves as professionals and continue to say that others should not look down upon us, then we have a lot to cover for us to be able to do clinical reasoning that they do, like they do, also to evaluate things like they do. So that when we refer to them, they will say, this is coming from someone that knows their onion. I'm not going to refer back. I'll just build upon what they have done. But if not, some of us are the ones that are going to cause problem for others. I know how to do that. But because someone used to send referral to the physician will just lump all of us together and say, where is it coming from? Physiotherapy department, just send it back. It doesn't even matter who sent it, whether that person has that clinical reasoning or not. They will just send it back. So please, we are going to take this very serious. Before people get certificate, we want to be sure that really we have learned together at the level that we should. Okay, so thank you. I think maybe we'll just go straight to look at the answer. So can someone different? I think I saw a hand when Victoria was trying to answer. Yes, I think Christian, is it Odwen, right? Christian, you are raising your hand. I thought maybe you wanted to help read. So help us read the answer, please.
Okay, thank you. The answer, not necessarily. This is more a case of need for additional information. Requesting a copy of the client's most recent physician's notes may answer all of your questions. Reading the physician systems review portion of the exam may reveal a record of these signs and symptoms with a corresponding medical problem list and plan. If there is no mention of any of these associated signs and symptoms, a phone call to the physician's office may be the next step. If you speak with the physician directly, identify yourself, your connection with the client by name, briefly mention why you are seeing this client, and make the following observation. Mrs. Jones report muscle cramps and generalized weakness that do not seem consistent with her SIJ problem. She complains of temperature intolerance and hair and nail bed changes. These symptoms are outside the scope of my practice. Can you help me understand this? Are they part of the lupus, Cushing syndrome, or something else?
Wonderful. Thank you. Thank you very much, Christian. Okay, what do you think of this? Can you see approach? Now, who will you send this to that will feel angry? It's like it's even in the extreme of being cautious, or someone will say it's too polite. But see how you can communicate with your colleagues that it doesn't send the signal that you are arrogant. You see, and that's another thing, is that if the patient is being seen, just because they have not written to you to say the patient has this organic pathology, does not mean you should write back to say they should look at this and that. You can consult. That is another decision. If the patient is not being seen for the condition that you are suspecting, that is when you refer back. But if the patient is being seen, it is not an issue of referral. It is an issue of consultation. You are seeing this case of Cushing syndrome. I need more information so that it will help me with this and that. That is what is supposed to be done, is consultation. It's not referral. Because if you refer, they say, we are treating this. What are you referring the patient for? He's already under treatment. So, but you are referring a case that is not been seen and it is not known, that you just identified, and therefore you are referring for them to see. This is also another very good one that has indicated that. Is there any comment on this answer?
Yes, please. Can I just comment something?
Yes, please go ahead.
My comment is, I love the report of the way it was answered. Like, okay, this is like you're communicating with the physician who referred the patient. But now, will this be tagged as, will it be written on a referral note or just a letter, or is this something you talk over on the telephone or something like that? Because this is not classed as a referral from here.
Well, it depends on your organization's structure and the way you do things. I remember someone mentioned here, I can't remember whether it was you, said, I reached out, called the consultant, we spoke. There's another organization that when you call the consultant, maybe you even have a fight on the phone. Why would you call me on phone about my patient? So it all depends on, I hope I got the question well. I was thinking of something when you asked the question.
Yeah, yes,
that's what you're asking
question.
for.
Yeah.
Yes, I think it all depends on the organization. What matters is communication. How you communicate it will depend on your environment, the context of the work that you do, multidisciplinary approach to things, and that is what will determine all that. But what matters is that at the end of the day, you get the information that you need to make the decision that you need to make. Any other comment?
Yes, sir. I want to
Yes,
speak to that last sentence. It looks to me, with our level of training and what we know, should we downplay on the understanding to this extent, as if you don't know what SLE is all about, as if you are just off the track, you don't, the way the statement was, I don't actually, I'm not comfortable with it. Though we should be simple, we should not be confrontational, but I don't think we should play ourselves, except the person did not have what it takes or the knowledge of what he feel it should be presented. The way it is coined, I don't know. That's my own personal opinion.
Remember I mentioned something like this. I said in the continuum of being polite, it is at the extreme end. But what I think this person is doing, because if you look at organic pathology, is not within the scope of my practice. I can know something in it, but I can still ask the person that it is within their domain to say, look, what's this about? So that they can give me a better perspective, because they are the ones that are in charge of that. Just like I'm expecting them, when they are talking to me about what is within my scope of practice, let them not show me that because it's like a patient coming and say, I have osteoarthritis. And the doctor will say, who are you to tell me that you have osteoarthritis? This is my job. And this is a very common thing, that someone will come and talk using technical language. And the doctor or physiotherapist will take offense and say that, no, you came here for me to tell you what your problem is. Why should you be telling me what the problem is? If you know the problem, why don't you go and treat it? They do that. So this is just looking at it from the context. Lupus, this is an organic pathology. Look, it's your field. Please, can you tell me what's this about? And that is what I'm expecting from him too. When he comes to me, he should tell me that although I know something about physiotherapy, but please, this is your field. Please educate me. What is this about? So this is what I think this person is doing. And I've said it earlier, it is at the other extreme of being polite, but it's up to us. There, they don't mind. In the UK, believe me, my professor once told me, look, whenever it comes to the issue of coordination of body segments, this is not my area. I got grant to do this research. Of course, I'm in neuro, but my main specialty is in force. Please, anyone that comes on this matter, I'll refer to you. A lady came from Netherlands, and she wanted to do work with her in that area. And she said, please go and meet Rufai. Because of the way they are polite, the lady said, please, can we go and take a coffee somewhere so that we can discuss? We sat down, and in the discussion, say, this is why we are having this. I just want to appreciate you for giving me more information. As if they don't know anything. They will give it to you that, look, it's all you, when they have background. So please, let's not see it from that perspective. They have their own culture, they have their context. This is not Nigeria. This is the US. So if in our context here, if we go that low, it might turn into something negative. Then we can now shift from the end of the extreme of the continuum to moderation. But for them, I don't think this is a problem, because in many other case studies, you are going to see something similar. It's common to them, it's not an issue. But thank you, Ma, because we are looking at our own perspective, not the UK or US perspective, and therefore we must really do things that will not degenerate things into something that will have to affect the image of anyone. So collaboration with other specialists is necessary for the welfare of the patient. Yes, having effective verbal communication skill is an important skill that every clinician should have in MDT. Yes, collaboration with other specialist physicians is so crucial to successful healthcare practice. As in this particular case, there's no big manism in the practice. Thanks, Prof. Back to the referring. Okay, so thank you so much. Thank you. I think it's very important to look at our context. And I would say that's why I keep saying it depends on your organizational structure, on the way you do things in your organization. So that I will not go and be saying, do it this way or do it that way, and you go back and you start to have problem with the people that you work with. So if in your organization, this is what would be best to maintain your dignity, please do that. Because the moment you go below that, you are going to have a problem, and you'll be the one to blame for that. So let's look at the context of where we work and act accordingly. Thank you so very much to everyone. I think it's always already 3:40. I don't think, maybe I think I will stop here. Even if there is another system that I've not looked at, we'll wait until Wednesday. So I picked only one from the systems that we have looked at. This is endocrine, I think. Okay, I also picked urological. I picked genital and maybe one other. So on Wednesday, we are going to pick the remaining and also go back and pick more within those systems that we only picked one case study. But most importantly, and if we can have as many as possible, we'll not even look at these ones that are not within our context. If everyone can send a half page of a case report related to systems review, they will be the ones that we'll take and discuss on Wednesday. But if we don't get enough, then we'll go by the Goodman and Snyder cases and discuss them. Yes, Mr. Anozie, go on. Let me call the name now. Nwabunwani Anozie.
Thank you very much, Prof. Yeah. Thank you so much for the training, and faculty. It's still an eye-opener in every system, and I love and I've learned a lot. I'm just a little bit want to chip in something about the physical therapy assistants or aides. Yeah, because I've seen that, okay, I'm looking for the way forward now. If the physiotherapists will really have to do a thorough evaluation of our patients, following the approach that we have learned, the system review. And we know that, and our expertise is actually on that evaluation, the ability to evaluate. The professionalism is in the ability to evaluate. So now, owing to the fact that we have, I don't know, the caseload of our patients usually is so much, and compared to a physiotherapist there. But I know that in developed countries, in the UK, in the US, it's standard for a physiotherapist to work with a physical therapy assistant who are also trained by physiotherapists to deliver interventions after they had evaluated and had formed a treatment plan. Now, how do we want to, because now in most of our hospitals, we use a lot of, what would I call it, health attendants who are not really physiotherapy assistants. And some people within the department just give them some form of training, help us to bring this, help us to bring that. But in developed countries, they actually are able to manage non-complex caseloads, and they are also able to, deliver the therapy plan after the physiotherapists have done that. And because of that, physiotherapists are now able to do more of their professional work more and have these MDT collaborations. So I'm thinking, is there anything that the board can do for us to have it a formal training? I know that we don't really want, some people are skeptical about training physiotherapy assistants because they feel the regulation will not be there, people will go into quackery, but I don't think so. I actually believe that if you're a professional, you're a professional. What makes me a professional is be able to know the science behind what I'm doing, and also being able to, have a broad knowledge of pathology, pharmacology, and able to integrate all those things while I'm evaluating my patients. And so no matter what you train a physical therapy assistant, you are not going to train them using the physiotherapist curriculum. So can we look forward in the years to come to make it compulsory that, there will be physiotherapy assistants, formal training that people could go in, maybe pick a form, like a diploma course, do that and be trained by physical therapists, so that when they are employed, they are now coming to work and have their own job description that is very peculiar to them. And it also now help us to be able to cover a lot of patients within our hospitals. Thank you.
Okay, thank you very much. I think there's a plan already on ground. I remember when I had a discussion with the Minister of State for Health, that's the current Minister of Education when he was Minister of State, said, this is our fear. And he said, well, we will empower you. So write to all hospitals and let them know that as a regulatory body, you don't allow for them to take people that cannot, that they won't have anyone to supervise them. And we also agreed, I explained to him that if we are going to allow the assistant program or technician program to continue, that we can only allow it in place where there are many professionals there that can supervise them. So we can't go to a state where there is no program and there are only few professionals, and then you now start a formal program that will bring many people that want to practice and the supervision is not there. And so there are a number of things, and our act has empowered us to do these things. And we are going to do them. But what I keep saying is that fear should not stop us from giving the populace what they need as per service. I'm happy that you mentioned our workload is even more than that of the US. So if it's more, why are they even adopting the assistance and we are not? So let's focus on the regulatory thing. And it is up to us to do that job. When the board does not have the manpower, we said, let's go for volunteers. And the volunteers have been doing their job, sending us information. We'll now send our staff and police to do the job. I know we have a case in Delta right now and a case in Ekiti. We have written to police and we are waiting for them just to say, this is the person that will go with you. And maybe within next week, they will be mobilized with our staff to go and apprehend people. And we have started that. And we'll continue to do that with the help of professionals because we don't have the number of staff to be able to cover the whole country. So we'll do that. By the time we do that, we'll open it up. In fact, I think we have done one or two, I think maybe one last year that we accredited for the assistant program. And they're going to start. It's a new program. The old ones, if they want, we'll revive them. But we are going to make sure before we do that, we have very strong regulatory mechanisms. Whatever deficit we can be able to cover, there is no place in the world where they eliminate quackery 100%. And therefore, our goal is to reduce it to the minimum that we can so that the populace will have the services and we reduce the effect of our decisions on the population. So these are some of the issues, but we need all the support that we can get from everyone. Thank you. Ademola Alajide. You have to unmute.
Hello.
Hello, yes, go ahead.
Oh, good evening, everyone.
Okay, you two have raised your hand. I didn't even notice. Okay, go ahead.
Okay. I just wish to really thank you for this step and to encourage everyone here to continue. And for the fact that you're making it so beautiful, getting us involved in the things we are doing. So it's one thing the usual thing people usually know is to register for a course, and whether you like it or even if you're learning or you're not ready to learn, you get your certificate. I mean, you're moving on from the usual thing to the world class. I just want to tell you thank you. And also I wish many physiotherapists could join this. I mean, seeing just 45 people, 50 people is really not a good thing. I wish people should just be into the beautiful work you're doing. I mean, if we learn all this and we operate from the world standard, that could be so better for us. And it will help us to practice more, get our patients to be better. Just we should say thank you so much, Prof. And you're challenging us. So people shouldn't see that when you're called upon to say something. I mean, you paid for this. You want to get involved. So we should all be open to be really involved. Yeah, I know that we are busy with family work and everything, but getting involved in what is being taught and making an input, it's so beautiful. Thank you so much, Prof.
Thank
I
you.
really do
Thanks so much,
that.
Ngozi. I appreciate you. Yes, Ademola, if you are not there, then Adeneko.
Yeah, thank you very much, Prof. Actually want to thank you for these very educative, interactive sessions. I wanted to talk concerning the last issue you mentioned about the assistant therapists. We also need to be careful with it and look at it from different perspectives. Take, for instance, for the pharmacist. When there is advertisements in some of the hospitals, when they are taking new staff, you see that they will advertise and they will pick 2 pharmacists, and the technician or whatever they call them will be taking like 20. And when you even go around, there are a lot of, most especially in the state hospitals, you see a lot of departments that are being headed by the pharmacy technicians, even when that is not even the agreements when they are starting it. And I could also remember about 2 or 3 years ago when both the pharmacist and the technician, when they are having serious issue with each other, that they are having their own board separately. They don't want pharmacists to control them again, to the extent that they went to court or something like that. And at the end of the day, it was court that actually stopped them, but they have some kind of partial freedom. And even in some of their departments, you see the technician having their own head, while pharmacists have their own head. And because of that game of number, they do have their ways in most of the things, most times. So in physiotherapy, we shouldn't be looking at the issue of the quack practicing alone. The boss should also look at the other way, that hope this one will not create unemployment, because majority of these people, by the time when they have 1 or 2 physiotherapists in the department, they go in and bring in a lot of assistants, and they don't even feel that they are short staff again. So we need to know or to take all that one into consideration in our policies. Thank you very much.
Thank you very much, sir. And I appreciate this. Sincerely, whenever I think of this matter, in my mind, I feel uncomfortable that I have to do this, even though I know there are issues on ground that are very serious. But let me give you an example. I'm happy that you brought the issue of pharmacy. Now, they will take 2, they will take more assistants. Now, in physiotherapy, there are no assistants. But tell me how many hospitals take compared to pharmacy. They still take less physiotherapists than pharmacy. Maybe sometimes they will advertise no even physiotherapy, but you'll see pharmacy. Sometimes they will advertise they will take only 1 physio or 2 physios. So what I think is that it's not the fact that there is no assistance that is making them to take more professionals. It's just that they have made up their mind, this is the number I'm going to take. Whether they are assistants or no assistants, they will not give you employment. So not bringing in assistants is not going to increase the number of professionals that they are going to take. So this is the situation, and that is what they have made up their mind to do. But what is going to change all that? Your specialization. Any hospital will want patients to come so that they can get money. If I specialize and I open my own clinic, patients will not go there, they will go to the clinic. And then at some point, you'll see that they begin to value whatever it is that you have, and you go there. Last week, I gave an example with a CMD that had a problem, and he was treated by a physiotherapist that he felt so much impressed that he opened up employment opportunity to the extent that he had to pick the slots of another profession and give it to physiotherapy. I think this is what I believe we should do. And that's why I said, before bringing in assistant program, I must strengthen the process of advancing our own practice. And this is one of the products of that plan. We are having systems review. We have the clinical pathway. We are working with the postgraduate physiotherapy college to see that it also strengthen itself to be able to provide that specialty that we require. If we continue on that path, then the other end will now be strengthening the regulatory mechanisms, and then we'll now be bringing in the assistance little by little and monitoring what will happen to see whether we should maintain it at that level or we should increase the number. But with all these concerns that people have, I think what I'm going to do in the next 2 or 3 weeks, I'm going to call for a meeting of stakeholders, and the subject will only be this issue of assistance. And I will tell people point blank, I'm not calling for this meeting to discuss whether to do it or not to do it. We have made up our mind we are going to do it. But the discussion is going to be about how do we mitigate the problems that will come as a result of having it? How do we have a strong regulatory mechanisms to control whatever problems that could come from it? I'm sorry that I'm being too rigid to say that I'm not going to present the case for discussion whether to do it or not, because it's already evident the society needs this. And therefore, if society needs it, there is no way because of my personal interest that I will say, someone will come and tell me, don't do it because I will lose my job. The primary thing is that the society needs it, and therefore we must give them. But how do we do it in such a way that I will not lose my job? That is what we are going to discuss, because that is what we don't have a solution to at the moment. But I truly appreciate this, and I assure you, I will be careful. I will have a listening ear as we go through with this, and we'll make sure that we do the best that will help both the patients and the therapist. Thank you so much for that very good admonition. Yes, Mr. Sunday. I hope I pronounced it well. Let me not be shying away from the names. Let me mention them so that I will be corrected. Yes, sir, we are listening. I hope it's not your network. Okay, maybe before you get back to us, can we take Odwenyi Christian?
Yeah, thank you, Prof. Hello, thank you, Prof.
Yes, okay, thank you. Yes, go ahead.
Okay, okay, sir. Hello? Hello, sir.
Yes, Mr. Sunday, please wait. Someone has already started speaking. Mr. Sunday, let Christian finish.
Yeah, thank you, Prof. You actually talked what I wanted to say in a bit, but this is how I would have loved, or what I want to suggest. Now, a whole lot of things from the aspect of upgrading the profession, in the aspect of clinical specialties, in the aspect of DPTs, are on the pipeline, in the sense that all these things, in as much as the programs have started, they have not taken root to the extent that the hospitals are beginning to recognize them and employ physiotherapists, maybe as a musculoskeletal specialty, as a pediatric physiotherapist, and they have not started employing physiotherapists as doctors of physiotherapy. Now, this idea of physiotherapy assistant would have been best when these programs that strengthen the profession is already in place and have gained recognition across maybe the hospitals and even in the nation at large. Then you introduce physio assistant, it will guard against abuse, where a situation whereby the employers will just absorb technicians alone and then close the door against the real professionals. So I suggest that in as much as the physio assistant program can still be on the table and then planning, but time can still be, it can still wait a little more, so that these other effort the body is making and you are making towards strengthening this profession, we begin to gain ground. This year, next year, they will start producing first graduates of doctor of physiotherapists, and then effort will be made to ensure that the hospitals are beginning to recognize them and employ them. So, and then the people that are specializing through postgraduate colleges are coming out with different specialties. When these things are in place, it's easy to work with technicians. It's easy to work with assistants. Thank you, sir.
Thank you very much. As I've said, I'm going to call for a meeting. But sincerely, if we are looking at this from both the sides of patients that are out there stranded and our side that we want to protect our interests, believe me, we have to shift ground. And as I've said, I'm not going to discuss doing this or not doing it or when to do it. I'm going to discuss how we can be able to solve the problems and make sure it does not affect us negatively. So let's leave all these discussions until we call for that stakeholders meeting. But I assure you, we are going to do this and we are going to do it immediately. But we'll listen to how we can do it in such a way that it is not going to, because what we are doing here as a responsibility given to us is to protect the interests of Nigerians, not just to protect the interest of physiotherapists. Physiotherapists are a very small number compared to Nigerians. And the problem you will have is a very small one compared to the problem that the patients have. Because you can be able to go and do PP, get money. But those patients will be there with disability. At the end of the day, they will be going out. Some will be begging. Some will have depression. They will die. And this is the bigger problem. Not having a job is a problem, but it's not as much as people dying. It's not as much as people having disability and becoming dependent on the society. So please, let's not discuss the issue of doing it or when to do it. Let's just discuss the issue of how do we come in to make sure as we are doing it that it doesn't create negative consequences that will affect a particular section of the society. This is what I'm going to continue to talk about. I'm sorry, Mr. President, maybe I'm not agreeing with you, but sincerely, when I look at the society and I see the responsibility on me to be able to help the society to get out of its biggest problems, I see our own problem as something that's not up to that. Although I also have responsibility to my colleagues to make sure they don't lose their job, I am always in this office trying to do that. I'm always in Ministry of Health, Ministry of Education. I go around. Yesterday, we were having a program. They say, what are the highs and lows of 2024? I said, I've been to over 25 states. And these travels that I left my family to travel is all in the process of making sure my colleagues get the best in their hospitals and in their universities and things like that. So I will never stop that. But the same way that I'm trying to do things that will help my colleagues, I will also do things at the same time that will help the most vulnerable people in the society. So that is just finally on this matter. Thank you so much to everyone. I can see there are no other hands. I want to appreciate you and thank you for all that you have done. Just like I said earlier, that all those that have been contributing, I don't want to keep mentioning names, but we know them. So Dr. Jibril Samani, because why I said they should give names, we want to train the trainers program that will last for about 6 weeks. And at some point, we are going to have them meet in one place so that we'll do hands-on. And then after the whole thing, we'll certify them. And then we'll now encourage wherever DPT will be done, they will be the ones possibly to be brought in to teach. Even if it is not about DPT in institutions, workshops that will continue to have to make sure this issue of systems review is going everywhere and being impactful, they will serve as resource persons. So we are going to plan it in such a way it will be easy for them, cost-wise, and also the processes, the lectures, the timings, and all that. So we are going to choose academicians and clinicians, at least one each academician, one clinician from each of the states where they are available, especially because I know it's not every state that has academicians, but the clinicians will have at least one person from every state so that after they train the trainers, every state should be able to have resource persons that can step down to people within that state. So for those that have been making comments on this platform, from the time we started systems review until now, your acceptance into the program is automatic. Dr. Jibril Samani, you know all those that have been contributing, it's automatic. And then for others, we'll now have a way that we are going to select, because we are not going to have a big number, so that it can be manageable. Thank you so much. May God bless you all. Dr. Jibril, over to you.
Thank you so much, sir. And we thank each and everyone for participating. The last session for the system review will be on Wednesday. And then from then we enter the specialty part of the workshop. So thank you all. See you next time.
Thank you, sir.
Bye.
Thank you.
Thank you very much. Yeah.
Thank you very much. Thank you.
Thank you so much.
Thank you, Prof. I do well for you to read some of the charts, please.
Thank you, sir.
Soldier, how are you?
Okay, sir. Hello, sir.
Well done.
Sir, this thing you are discussing of this assistance, sir. Sir, it's going to be of value to us because they even created this school, NAP Samsung. The one that they have, like the one they have in the army, sir. So that's one of the way that we in the military, the physiotherapist officers in military can grow, sir.
Okay.
So we appreciate it, sir. We discuss it further with you in the cameras.
It's all right. Thank you very much.
Thank you, sir. Yes.
Thank you, Prof.
Thank you very much, Ma. Thanks a lot, Ma.
I'm grateful too.
Thank you, sir.
Thanks.
Oh, thank you.